put it here, we define we put a simple rod on the lateral aspect of the leg, just anterior to the fibula. And we take a picture, we take a C-arm to be aligned with the longitudinal axis of the tibia. There is a trick here and a hint for surgeons. And when the rod will pass by through the lateral process of the talus. And this will give you really a good idea that we are on the right track. When you take as a reference an anatomical landmark, you will take it as a reference to the lateral process of the talus. So then you draw the line, you draw the lateral line, and you continue this lateral line, you will continue it on the lateral aspect of the heel. Then afterwards, you will take the step 2, you will define the axis of the calcaneus based on an axial view of the calcaneus. So you will put a vertical line, and this is the axis of the calcaneus. And with an axial view, you will help, and you have 2 lines. The point joining the 2 lines, the bisector point, will be the ideal entry point for your nail. So this is based on anatomical landmark, which is quite automatic. So afterwards, after preparation, so this was before surgery, after preparation of the joints, maybe only the ankle joint, maybe the ankle and the subtalar joint. After preparation, you will put you start to create your entry point using retractors. So it should not be mini invasive as for 1.5 centimeter or 2 centimeter. Go for 3 centimeter, it's okay. So you need to dissect down to the plantar fascia, and when you are feeling the bone, you will take the knife and you will continue, you will make a stab in the bone. Using retractors, because it's very easy seemingly to make injuries to the lateral plantar bundle. So on the lateral view, you have your entry point already localized, and you will try to extrapolate the line of the guide wire into the tibia, like the figure on the right side. So you have it inside the tibia while reducing. So the important thing is you need to recheck your entry point during surgery. You prepare your joints on the ankle and on the septalar joints, and once it's prepared, once you have like these lines, these joint lines are parallel to the plantar surface, so now you can insert and you can try to insert your guide wire. So on the AP, you will do the positioning on the AP. You have a nice guide wire on the lateral and on the AP, and as you may see here, the tip of the guide, it's away from both cortices, so you don't have you will not, and you have less risk of injury of the cortex, of fracture, iatrogenic fracture, cortical fracture, or afterwards, if it's close to the cortex, you might end up with the hypertrophy of the cortex. So afterwards, you start reaming. You are in a good axis both on the lateral and then on the AP. And as you may see, our fingers we are putting, or we are keeping the foot into the reduction with our hands. It's essential that once you decide to put the guide wire, the foot should be in the reduction position as planned. And this is the final aspect of the intramedullary nail. You have it inside, quite in the midline at AP and on the lateral view once you did it. So you have really nice view, and you have nice X-rays at least for this nail. So the advantages: there is no measurements to do. The landmarks are radiological, anatomical landmarks. The entry point, it depends about 2 things: the lateral aspect of the ankle and the axial view of the calcaneus. It is a simple, reproducible method, and it takes into account the calcaneus position, be it in neutral or valgus or varus. So you make the correction of the deformity of the calcaneus, and then you have the lines parallel to the plantar aspect, and then you can insert your gate wire. Thank you.
Thank you, Cesar, for this presentation. Any questions on the floor?
هذا يعطي please.
Cesar, thank you very much for this very nice presentation showing tips and tricks. What I do usually, I haven't really done a lot of these arthrodesis. I have done a few, and when I do it, I to be sure on the mediolateral aspect of the calcaneus, I go to the bone. When I am on the bone, then I do a palpation of the lateral cortex and of the medial cortex to be sure that I'm not medial or lateral.
Absolutely, you can do it. Absolutely, it's a good way, in fact, like to recheck.
I put like two small homins. And, I palpate with then I go in the mid.
Absolutely, you can do it. It's difficult to put the gate wire and to go medially just on the border and then laterally just on the border. It's difficult, but it's
to make a bigger incision. You can do it.
Yeah, you can do it. Reason why I always say don't go
easy.
for very many invasive. Go for a 3 centimeter wide open, and then put it, because it's the most important step.
Yes.
When you want
sure.
to put your nail, really. Otherwise, you will end up with a malpositioning.
Hello, Cesar. I have a small question about the debridement, avivement of tibiotalar and subtalar joints. It's done before or after the insertion of the nail?
It's done before. So you will mark your point before surgery, just before even putting any draps. Okay, so you'll make the theoretical entry point, and you have an idea a little bit about the entry point. Then after you will go, you will make joint preparation and everything. You will remove your cartilage, and then you reduce it as you wish, and then you will do it again, the entry point. So you didn't touch the calcaneal plantar aspect yet. So once you prepare your joints, you will put it into reduction, and then after you will do the same. You will take the lateral line, and then you will take an axial view, and you do the same. Sometimes it's the same entry point, sometimes it's just next by. But the thing is, you have an idea where is the entry point, and then you can play with the stick of the gate wire. And you can go a little bit laterally, a little bit medially, but you know where to put your gate wire. And I think this is really very important.
And usually you keep the fibula or you remove
what?
it? The fibula. This is the fibula. You remove it or you keep it?
I remove like 7 to 8 centimeters of the fibula. Okay. And I can use it, either I will take the half of the fibula and I put it lateral to the tibia and talus, put some screws in it, or if I need more bone graft, I will use it in totality, I will morselize it, and I will put it inside the joints, specifically for the subtalar joint. When you have, for example, a Charcot, you need to, the talus is totally damaged, even the calcaneus.
Thank you.
Will you do an open debridement of the subtalar, or just to rely on the reaming?
Open debridement of what?
Of the subtalar joint, or
open.
Or sometimes you can rely on the reaming of.
You should not rely on the reaming
no.
Because it's a big surface.
And some authors they do not debride it specifically. They rely on the reaming of the subtalar, and
I know, but the reaming of the subtalar is just like half of a centimeter, while the subtalar area is very big in terms of surface, of contact surface. And if you don't remove the diseased cartilage, you will not be able to fuse. So they will count, these authors will count on the tibiotalar
No,
fusion.
do you mean according to the indications?
Yeah, if you need to fuse the subtalar, you need to remove all cartilages.
It depends on the situation. If you are going for a tibiotalar and subtalar joint arthrodesis, you have to prepare it completely. If you want to do tibiotalar arthrodesis without blocking the subtalar joint and you just need to cross it, you should remove the screw after 6 to 8 months, and this will keep some mobility in the subtalar joint. The only pitfalls, it might become very painful after all. So it depends on the first indication why you are doing this arthrodesis.
The technique, the indication of Alain, what he's saying, usually they use it when you have a complex fracture of the ankle in a diabetic patient. So they will put the retrograde nail and then afterwards they will remove it. But usually it will not hold. If you don't do fusion, there is a high risk of complications. It will not hold.
Thank you.
Thank you, Dr. Kaysar, for this nice lecture. My question is why we should cut the fibula high 7 or 8 centimeters and to leave it free, you know. Maybe it will make some pain later on.
It depends about the indication. So the indication, if you want to fuse your tibiotalar joint and the subtalar joint, you need to go, usually it's in varus, usually the deformity is in varus. So you need to go into the joint to remove the cartilage of the subtalar joint and of the ankle joint. So you remove it to have a nice access to the subtalar joint and to the ankle joint, and then you will use it as a cartilage, as a graft. This is the way that you want to do, because you need a fixation, you need a stable fusion.
Yes, but why this cut of fibula it is so high, 7 or 8 centimeters?
Because if you want to make it as a graft, like half of the tibia in a longitudinal aspect, if you cut it into a half, so you can bridge the tibia, talus, and calcaneus with this, with the 7 and 8 centimeter. If you want to use it as a graft into the joint, you need more than 3 and 4 centimeter. So you need the graft. You need to take the graft, and the access is nice, and you don't have complications if you go even up to 10 centimeter. So you don't have any complication when you remove the distal part of the fibula.
Thank you, Cesar.
Thank
Now
you.
we'll go on with Dr. Ali Sleiman, who is going to be speaking about complex tibial pilon fracture.
Good morning. First, I present a case of 68-year-old male patient presented for right ankle trauma after falling down from 3 meter high. X-ray show right tibial pilon fracture comminuted with metaphyseal impaction and distal fibular fracture. Comorbidities, coronary artery disease, diabetes, and peripheral artery disease. Patient underwent ankle fusion, ankle arthrodesis, subtalar arthrodesis. At 6-month follow-up, X-ray show subtalar fusion. Patient was walking without a limp, without pain, and to do complete squats. Pilon fractures are intra-articular fracture of the distal tibia that typically result from high-energy injuries. They may also involve metaphyseal extension and can have associated fibular fracture with significant displacement, articular comminution, and extensive surrounding soft tissue compromise. Many classifications are described. They mostly stress on the presence or absence of metaphyseal comminution, articular comminution, and metaphyso-epiphyseal impaction. The condition of the soft tissue is crucial criteria for the therapeutic decision and a major prognostic factor. Schering classified associated soft tissue injury in 4 types: grade 0 minimal tissue damage, Grade 1 involve superficial abrasion, and grade 2 involve deep abrasion. Grade 3 present with extensive skin and muscle damage, subcutaneous avulsion, and or compartment syndrome. Radiographic evaluation is based on AP lateral oblique and Mortise X-ray views of the ankle, CT with 3D reconstruction, and angioscan is indicated in case of suspected vascular injury. Treatment modalities, OREF is commonly considered as the treatment choice. However, aging population may not be best candidate for surgery. Treatment may accordingly consist of reduction and non-weight bearing immobilization for 6 to 10 weeks in a cast. Some authors reported good outcome when performing OREF early as possible with reduction of hospital stay and less complication. However, results are not similar for low and high grade energy trauma. Poor outcomes are seen in high energy trauma, comminuted and displaced tibial pilon fractures, and in presence of comorbidities. Moreover, multiple studies showed in early OREF an unacceptable high rate of infection up to 40% and wound complications. This results in poor outcome with high rate of revision surgeries, non-union, osteomyelitis, and arthritis. Temporary ankle fixation, temporary ankle spanning external fixation is usually used as damage control surgery and before a final planned delayed OREF. External fixator also can be used as definitive treatment in some indications, such as highly comminuted fracture with important soft tissue damage, Gustilo type 3, significant comorbidities where OREF is associated with high risk of failure and complications. The most common complication associated with the use of external fixator is septic arthritis and osteomyelitis. The main goal of open reduction and external fixation is to restore anatomical articular surface and rotational alignment. At an average of 3.2-year follow-up, Pollock and colleague reported ankle stiffness in 35% of patients and persistent pain in 33%. Harris and colleague found post-traumatic arthritis in 39% of patients with complex fracture at average 26-month follow-up. Primary ankle arthrodesis has been proposed an alternative treatment in high-energy fractures with complex articular comminution that have low chance of adequate reduction. Potential advantages include accelerate recovery, decreased complication, include wound infection, and improved functional outcome and pain. Indication for primary ankle arthrodesis, non-reconstructible pilon fractures, fracture with significant comminution. Without anatomic reduction, there can be rapid progression of radiographic symptomatic arthritis, and areas of comminution can develop aseptic avascular necrosis, which can lead to collapse and non-union. In delayed definitive treatment, high-energy pilon injuries associated with other injuries or unstable hemodynamics that may postpone definitive OREF beyond 3 to 4 weeks. After that time, mobilization of fragment can be difficult. The cartilage rail can be destabilized. Open fracture, blisters, and abrasion with traumatic wound can limit surgical incisions. Another indication, multiple medical comorbidities. In a retrospective cohort of 95 pilon fractures treated in a staged fashion, White and colleague report reoperation rate of 50% in patients with diabetes or schizophrenia and 40% in patients with alcohol abuse, compared with 66% of entire cohort. Staged delayed primary arthrodesis for these patients allow for increased time for the soft tissue to recover. Patients factor, obesity, altered mental status, limited mobility or living alone. Definitive treatment with tibiotalo-calcaneal arthrodesis using an intramedullary nail is an option that allows for early weight bearing with a load-sharing implant. However, this comes at the cost of subtalar motion. Another author reported on a patient with a history of seizure, stroke, hypertension, smoking, and cocaine abuse who had a complex fracture treated with staged primary tibiotalo-calcaneal arthrodesis. Despite immediately weight-bearing against medical advice, she achieved fusion and was satisfied at final 17-month follow-up. Peripheral neuropathy due to this patient have due lack of protective sensation. The advantage of using primary arthrodesis in this patient is to allow for more rigid fixation, as ORF may create failure and wound due to early weight bearing. The option to achieve arthrodesis, ankle arthrodesis with open reduction internal fixation using plate and screws. With external fixator, the patient's soft tissue may not be able to tolerate large or multiple incision above the ankle. Acute infection from an open injury or ORF that require hardware removal, irrigation, debridement, and IV antibiotics. Ankle arthrodesis with intramedullary nailing. It's a strong implant, allow for early weight bearing. Intramedullary nailing sacrifice subtalar joint motion. This method is reserved for low demand patients with socioeconomic factors that preclude extended non-weight bearing or neuropathic pain. In a comparative retrospective study between primary ankle arthrodesis versus ORF for comminuted pilon fractures, outcome reported by foot and ankle outcome show no significant difference in pain, and the quality of life, sport, or activity of daily living was observed. The more severe symptom experienced by primary fusion patient can be attributed to compromised movement at the tibiotalar joint. Another subscale reported for primary fusion patients report more severe physical role limit and pain, but all mental health, physical function, and general health subscale were equivalent between both groups. What about union? When deciding between primary fusion and ORF in severe pilon fractures, one must consider the patient prognostic course and the role of the vascular supply of the distal tibia in achieving union. More than half of high energy pilon fractures present with vascular insult to the distal tibia that is further jeopardized upon ORF and may increase the risk of infection or non-union. In this study, we observed non-union in 5 of 19 primary ORF patients and 1 of 16 primary fusion patients, all of whom required further operative intervention. In summary, primary ankle arthrodesis is a viable option for high energy pilon fracture that are non-reconstructible in patients with local soft tissue condition, compromise in patients with multiple medical comorbidities. It's decreased the complication rate and pain. It can potentially accelerate recovery and decrease pain compared with upper reduction internal fixation in certain scenarios. We suggest that primary ankle arthrodesis is safe and reliable method to fix highly comminuted pilon fractures in a unique subset of patients with significant cartilage damage. Despite more severe injury in patients receiving primary fusion than those in whom reconstruction could be attempted, the functional outcome between both patient papillary are similar. Moreover, as we observed more non-union in ORF, primary fusion should be considered in tailored subset of patients as definitive treatment to reduce the need for further operative management and lessen long-term morbidity. Thank you.
Thank you for the presentation. Do you have any question on the floor? I have one comment. Just these are difficult fractures and difficult topics to nail. And on the picture, the first picture that you showed us, we can see the perfect positioning of the nail, but we have a very widening of the ankle itself. So when we have to go and treat to do it for these complex fractures, just pay attention to restore the length of the leg and try to reduce the widening by the positioning of the lateral and medial malleolus. And you can do that intraoperatively by putting a temporary K-wire as a joystick. You can reduce them, and then when you put the nail, you can leave them at their place. But
Okay.
thank you for the
Merci.
presentation.
Just one question, another question. Very excellent remark from Alain. I have two things to say. In addition to reduction, perfect reduction, as Alain mentioned, you need to graft it also, because usually you have a defect, a bone defect, which is a huge. So just to collect the bones and to put the nail, it's not sufficient. Good, you have a nice union here, but usually we have a very large defect bone in the distal tibia, metaphyseal bone. Second, what approach did you do? Was it anterior approach?
Ali is a resident
Oh, okay.
department. He prepared this presentation alone. I didn't intervene. Ali, thank you for this very nice presentation.
Thank you
لا
for
بس
you.
بينترك يعني
إيه؟
بيعملها صح؟
إنه إيه، حطها على حاله إنه
Merci.
c'était bien. Now for the approach, because this patient had several comorbidities, so we tried to do with a small incision. This is why the ankle is large. Not make aggressive dissection and a skin compromise. He had a cabbage, a peripheral artery disease, he's diabetic. So we tried to do it with a really minimally incision in order not to increase the skin
Anterior
and
incision.
compromise.
Anterior?
Huh?
Anterior?
Anterior, yes. Yes, anterior.
مش عم يحكي مش طالع. Okay, Dr. Ali, thank you very much. You know, this is a decision, as you said, a little bit discutable with the patient and the relatives to do right away the arthrodesis, you know. Maybe it is the best solution and the best choice. My question, it is not good to put bone graft and to have a fast recovery right away after this operation.
Yes, it's an option, but إذا في ارجع بس دقيقة بس. بدي ارجع على الصورة بس دقيقة. تقصد بلا ما تعمل له arthrodese without doing arthrodesis? Arthrodesis was okay.
Bone grafting. There is bone. We didn't see bone. Okay. We didn't notice it, okay? My question was, it is right away to put bone graft during this operation or not arthrodesis without bone grafting? Yes. Yes, the question was the widening of the ankle, only the widening. My question is to put bone graft right away with this operation.
I didn't understand what you mean.
We do arthrodesis, you know. At the same time, we put bone grafting to have fast recovery.
And to restore the length also, not because as it was mentioned by Cesar, you mentioned that we should restore also the length because there is a يمكن there is a void في فراغ يعني from the comminution of the metaphysis and the epiphysis. So if you put a glue and you put in compression, it will shorten. So this is why the bone graft is also to fill the gap.
Okay, this is my question. Thank you.
Now we'll be presenting Dr. Alain Aii. He will talk about syndesmotic injuries, the new evidence.
Good morning, everyone. Can you hear me? Yeah. So we all know about the syndesmosis, where it is located, what are the pitfalls of treating it, and how much time we miss the diagnosis of having a syndesmotic injury. And by failing to recognize the diagnosis, we will fail the treatment, and patients will have a bad outcome later on. And one of the principal causes that we miss the diagnosis is the complexity of the syndesmotic anatomy and the location of the syndesmotic itself, because it usually occurs with some ankle sprain or some distal tibia traumatology. Here we can see that on the picture, it's a complex trapezoidal structure, and we have to make sure that we are considering only the anterior-inferior tibiofibular ligament, which starts from the distal part of the tibial plafond and goes to the point of the lateral fibula for about like 1.5 centimeters, 2 centimeters, and above it, what is relying the fibula and the tibia is the interosseous membrane, which has a role in the stability. We should not forget that we have the posterior syndesmotic stabilizers with the posterior inferior tibiofibular ligament, which is rarely injured in the traumatology, because this is one of the causes why we have this deformity in rotation when we have instability in the syndesmosis. If we look at the footprints, we can see where are these ligaments inserted on both bones, and this is important if we have to consider reconstruction in chronic syndesmotic instability. So just keep that in mind. And one of the issues why we have pain in the syndesmotic injury if we miss them is because we have a small cartilaginous confrontation between the distal tibia and the medial aspect of the fibula that, if it's not reduced, is considered an intra-articular fracture, and if it's not completely anatomically reduced, could be a cause of pain later on. So on the clinical examination, we try to understand the history of the trauma, and sometimes it's difficult. But to get this syndesmotic lesion, usually it occurs when we have an external rotation of the ankle when it is in dorsiflexion, and the position of the foot can be either supinated or pronated. And we can see that the more exertion is going to occur, it might lead to the fracture of the medial or lateral malleolus. What is particular about that is when we question the patient for more details and to point out pain, he's going to show the ankle itself. It's not going to be specifically pointing out at the syndesmotic region. So when we have pain at this region, it should just trigger a differential diagnosis in our mind to keep it there to follow the investigations later on. There are several tests that has been discussed in the literature to see how we can do the diagnosis of this tibial distal fibular instability. All of them has either a big sensitivity with a low specificity, but if we do them all together, this will give us a nice diagnosis. It's easier to produce these tests when we are in a chronic instability because patients have less pain. And if we want to check if we have any anterior translation of the fibula over the tibia, it's easy to do it. But in acute cases, it's difficult. In order to get the diagnosis done, even if we have a high suspicion, we should go for a complementary examination. The clinical examination itself is not sufficient. So we start with standard X-rays, and from preference, if we can do it, standing X-rays on AP and mortise view. And here we're going to calculate some numbers that you see, like the tibiofibular overlap, or the tibial clear space, or the medial clear spaces. These are things that we can see obviously if we have a real opening of the distal tibiofibular joint. But once this is unsafe, there is another new techniques that have been published in 2024, instead of doing the standing when the patient is standing on his both feet, we try to make him do the standing X-ray on one feet. And apparently this will give more specificity and sensitivity, but it's more for the chronic cases, or at least a distance from the trauma, in order to let the patient be on 1 feet. After the X-rays, we can go for CT scans. And here, what is essential is the CT scan is gonna help us to see if we missed any associated lesions, any cartilage damage, and it will help us to see the positioning of the fibula in this groove around the tibia. And we can assess also the tibiofemoral clear space and the overlap, and we can see the peroneal groove. If we look on the CT scans, on the literature, the first part is described to look for these angles, and it's difficult to get it done if you're not on the proper cut. While if we look on the lower scheme, here we have a clear way to do it and to identify if we have any rotatory instability with this distal tibiofibular joint by drawing this Gifford's tibiofibular line, and usually it would intersect with the anterior part of the tibial plafond. If we have any rotatory instability, as what's seen there on my far left, we can see that the fibula has turned, so they cannot intersect anymore, and here we have a rotatory instability on the distal tibiofibular joint. And the MRI remains the exam of choice. Why? Because it gives us more information about the ligaments, not only the positioning of the fibula accordingly to the tibia, what we can see on the CT scan, but we can see if we have any lesions of this anterior inferior tibiofibular ligament on its all aspects, and most importantly, it will show us if we have any cartilaginous lesion. In the acute phase, if we do the MRI, it's useful because we have the edema of the ankle itself that will give us this information. But for chronic cases, I advise you to do an arthro MRI, because if we see some leakage of the liquid within the syndesmosis, we know that it is ruptured, and it will confirm the diagnosis. Be aware when you interpret the MRI, because sometimes when it is interpreted as lesioned, in fact, because the ligament is trapezoidal, it depends on which cut you are, it might be just an illusion of the radiologist, and just check your MRI by yourself. Ankle arthroscopy is now a new method of putting the diagnosis, but we're not going to do an ankle arthroscopy for every suspicion. So it might be an adjunct as a diagnostic and treatment tool, because we can assess intra-arthroscopically if the distal tibiofemoral joint is opened by inserting the probe or the trocar, and if we see that it slides proximally, it means that it is disrupted, and in that case we can see all the ligaments as, within the same time. To classify it, actually the most simple one is to see if it is acute or chronic, and in the literature the consensus now is if it is more than 6 weeks from the trauma, we'll consider it as a chronic, and we will treat it accordingly. We always start for a non-operative treatment where the patient is immobilized in a cast, non-weight bearing for a couple of weeks, and then fully weight bearing for 4 to 6 weeks, and we start rehab. If it does not work, or if it's completely open and we have to reduce it, you all know that you can put screws. And here's the debate is, how many screws do we put it? 2, 1, 2, which millimeter? But the most important thing, if you want to do 1 or 2 screws, is how to position it. It should be within 2 to 4 centimeters above the tibial line, not higher, because it will not have any anatomic properties and mechanical properties to stabilize the distal tibiofemoral joint, and it should be pointed from posterolateral to anteromedial. And this is due to the positioning of the fibula according to the tibia. Even if we are using now the suture button, this remains applicable, but the only difference is it's not a rigid implant and it's more tolerable, but it's not stabilizing in all planes. Another way to do it is like you can go to the medial malleolus, draw it, divide it into 3 parts, then go to the lateral malleolus, draw it, put a line in the middle, and then mark 2 centimeters and 5 centimeters from the tibial plafond, and you can use an ACL guide to put your screws at 2 and 5 centimeters, and this will give you a more reproducible way to put your screws. And this is where it shouldn't be at 7 centimeters. For chronic instability, we have to go and do a lot of reconstruction with hamstring or gracilis or tenodesis. I'm going to just show you what this is. One tension of the implant stabilized and confirmed with one screw. Otherwise, we can go where the gracilis as an overloop and fix it with some anchors instead of screws. This will give us the stability without being too rigid. Thank you.
Any question? Yes, Ali.
Alan, thank you for this very tricky, really, pathology, in diagnosis and in treatment. I'm sure we are missing a lot of these patients in our daily practice. For the chronic lesions, what about the arthrodesis? I mean, the tibiofibular arthrodesis.
It's not the first option to do, because if you do it, the positioning, the perfect positioning of this arthrodesis is very difficult. Since the talus anatomically is wider anteriorly, if you do it, you might restrain some dorsiflexion and the patients will feel pain. So that's why it's better to get it some flexible stability. And when you do it, you always have to go and debride the remnants and the fibrous tissue and either take a gracilis and put it on the anterior part. You can fix it with 2 screws, or you just put the tunnels. But this, the arthrodesis is not considered a treatment now.
Because no, the concern, I mean, is about the pain after the ligamentoplasty, if you want to tell.
Yeah.
Ligamentoplasty. It's not really it's not really easy, let's say, to restore the anatomical relationship, as you mentioned in the first slide, the cartilage below. So the pain, the resistant pain. What do you think?
For chronic instability, and if you see on the CT scans that you have the rotation instability, what you can do is when you do your opening, you just have to check the positioning of the medial side of the cartilage of the fibula. It should match the lateral side of the talus. And then when you get the reduction...
Of the talus or of the tibia?
Of the talus, because this will show you that the fibula is in good rotation. And then you debride, you put a clamp on it, and then you do your ligamentoplasty in either way. But this is one of the anatomical landmarks that can help us to see that the fibula is facing correctly the distal talus and the tibia.
Thank you.
I think what Ali he was mentioning is very important. It's difficult. And even when you do the ligamentoplasty, it's difficult to evaluate the tension needed to put it into place.
Yes, yes.
So it could be easily we can go over tension or under tension when you are doing this ligamentoplasty.
You know, I'm maybe doing some extrapolation with the distal radio-ulnar joint. In the chronic instabilities, we go more for esophageal. You see what I mean? Because you cannot control the pain because of the cartilaginous lesion, of the fibrosis, and so if you block the motion, the pain will go.
But it will be depend on this rotational flexibility that the ankle need in order to adapt in uneven field. So
I have a case for whom I operated with a percutaneous technique of a fracture of the distal tibia and fibula with a percutaneous technique, and he developed
instability. Instability.
No, syndesmosis.
Stability?
No,
Fusion.
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 But this is not your fault. This is
this
is the trauma fault.
No, I mean, and he's well.
Next research
He's lucky.
topic.
He's lucky.
It will
Yes.
be a sovecapangi for the ankle. Next one. Next research topic will be a sovecapangi for the ankle.
The ankle.
Thank you.
Thank you. Dr. Hello again. I will be talking about a preliminary study we did it in our department over the outcomes of amputation with versus without metatarsal head resection for a single ray wet gangrene. This is for the diabetic foot mostly of these wet gangrene. عم بتسمعوني منيح؟ So to detail the aim of the study, first, diabetic wet gangrene is a very serious condition that could put at risk the limb and the life of the patient. There are usually two types of amputation that we can use when it is when the infection or the necrosis and infection are around the metatarsophalangeal joint. Either we'll go for a complete toe disarticulation or a toe amputation including metatarsal head resection. So very few published papers had talked about these two techniques as comparative outcomes, and we can call them either transarticular, when you go through the MTP joint articulation, or transosseous amputation when you go through the neck of the metatarsal head. So our study design is a preliminary study, as I said. It's a continuous series on 3 years with a retrospective comparative design between two groups, those with a toe amputation through the MTP joint and versus toe amputation with the resection of the metatarsal head. We usually, for the residents that they would like to go for research, you can use the Joanna Briggs Institute checklist for every kind of study design. It's simple to follow, very easy to apply, be it randomized clinical trials or cohort trials or match series. So our inclusion criteria for patients were first 4-foot location, a stage 4 of Wagner or a stage 3B of University of Texas infection of the diabetic foot. Those involving only single toe or single ray were included. Any revascularization required before surgery was allowed for inclusion. So the indication for the index amputation, the first amputation that we did, depend on two elements usually. We follow two elements. First, the level of soft tissue involvement, and it is clinical usually. And second, the level of bone involvement using MRI results. And for all our patients, we go for MRI. We do MRI prior to surgery to have an idea about the level of bone infection. So the first group of comparison is transarticular, the disarticulation group. It is the indication, it is performed when there is a gangrene distal to the MTP joint with at least 1 centimeter of healthy soft tissues. And on MRI, there is no signs of septic arthritis or proximal infection. The second group, the transosseous amputation, the indication is where the necrosis, the indication is when the necrosis is too close to the MTP joint, within 1 centimeter, or if there is a presence of a septic arthritis of the MTP joint or involvement of the metatarsal head. All cultures, soft tissue cultures, were sent to microbiology, and all bone specimens were sent to pathology. The outcome was defined. We had like 3 primary outcomes: healing rate, frequencies of infection recurrence, and additional surgeries, including reamputation. For the infection recurrence, we had 4 subcategories: same ray bone infection, same ray soft tissue infection, adjacent ray bone infection, or adjacent ray soft tissue infection. For the additional surgeries, we divided them into 5 subgroups: surgical debridement, partial ray resection, total ray resection, transmetatarsal amputation, and below knee amputation. Mortality was set as a secondary outcome. So the sample, we included 28 patients encompassing 31 cases that met the inclusion criteria, 12 in the disarticulation group and 19 in the transosseous group. The mean follow-up period was about more than two years and a half. So these are the baseline characteristics of our two groups, including demographic data and the risk factor data. There was no significant difference between both groups. The location of the wet gangrene and or osteomyelitis occurrence. So in the transarticular group, most of them were located in the 3 most lateral toes, whereas in the transosseous group, the highest frequencies were noted in the hallux and in the 4th toe. The signs of suggestive for osteomyelitis on MRI were 64% and 72% respectively for the transarticular and the transosseous amputations. So these are the location that we found. We already talked about them. The first outcome that we analyzed was the healing rate. Following index procedure, it was around 67% for the transarticular and around 58% for the transosseous amputation. Infection recurrence, the second outcome, it happened like 50% and 52% for both groups. Around half of patients had infection recurrence. Most infection recurrence were in the form of osteomyelitis, either in the same ray or at the adjacent one in both groups. There was no significant difference found between groups in any other subcategory of infection recurrence. The frequency of additional surgeries, half cases in both groups required additional surgery, mostly in the form of reamputation. It happened like in the third cases and around 50% of cases for the transarticular and transosseous group respectively. Major amputations were recorded in 2 patients only in the transosseous group. So these are our outcomes. The infection recurrence developed into the 4 subcategories, and the additional surgeries developed into the surgical, into 5 subcategories. To note that there was no significant difference between both groups, but a higher rate, absolute rate of below knee amputation in the transosseous group when you include the metatarsal head into your amputation. So a wet gangrene is a very serious disease. Even when treated within 24 hours, quite all our patients were treated within 24 hours of admission. The frequency of complication is excessively high. The healing rate did not reach 70% in both groups, and the infection recurred in half of the cases. As we discussed in the walk we presented, like this is our 4th study about the severity of infection into diabetic foot and what to do. We change our policy, in fact, when treating these infections. So we suggest to go for a more proximal level of amputation, not only take the 1 centimeter signal. You usually go proximal to the signal, MRI signal, 1 centimeter proximal as our level of amputation, our level of resection. It should be more. And usually when we talk with our colleague radiologists, they will say that it's just an edema. What you are seeing is just an edema. But it seems in the diabetic foot, it is inactive infection. We cannot state that what we are seeing on the bone marrow of an infected, supposedly infected bone is just an inflammatory edema. So MRIs usually, because they say always that MRIs usually overestimate osteomyelitis, our findings indicate the opposite. In the diabetic foot, we are underestimating inactive infection. So a reason why a more proximal level of amputation could be more efficient when dealing with severe diabetic toe. So a more radical approach if you want to take the key messages, when a wet gangrene presents distal to the MTP joint, the metatarsal head is to be excised, even if it's distal to the MTP joint. When the gangrene reaches MTP joint or the head, the metatarsal head, you will go for a ray resection up to the base of the ray. So, for example, here we had a case, osteomyelitis, it was a wet gangrene, including M4 and M5. On M4, we have an osteomyelitis of the head. On M5, we have osteomyelitis of the head till the proximal shaft, till the distal shaft of the metatarsal. When we did the MRI, as you may see here on M5, it goes to the half of the shaft. On M4, it goes just to the neck of the shaft of the metatarsal. And what we did, we removed nearly the total ray of M5, and we went to remove the proximal, the distal shaft of M4, including the base of P1. So, okay, this is a preliminary study. We acknowledge all limitations. It's a retrospective comparative one, low sample studies, and for sure, further trial, comparative prospective trials are needed. Thank you.
Any questions?
The metatarsal with the toe, the distal, is it functional? Is it? Don't have the experience, but just take.
Is it? I didn't get the question. Sorry.
Yani when you leave the proximal half of the metatarsal with the toe, the distal, the phalanx,
Yeah.
P2, P3.
Yeah, this we have now. I think we have more than 25 cases, I think, or 30 cases of internal pedal amputation. We call it. So we call it internal pedal amputation when you remove just the bone. If you have a nice soft tissue, when the infection or the necrosis doesn't touch severely the soft tissue, you can keep it, and you can remove just the bone, and you have excellent results. In fact, when you don't have any further complication, you have quite acceptable functional toe, and the aesthetics are very much appreciated by the patients.
You mean the form, the aesthetics?
The aesthetic form, and as function, you can use it. It's not as a normal toe, what I mean, but it goes with the gait. When you are moving
when they
your
put
toe.
the shoes, the toes, يعني ما بفوت
No.
لتحت؟
No,
No.
no.
Thank you.
Sometimes when you do a large excision, sometimes you do like nearly a total metatarsectomy, including P1, I put a cement with antibiotics as a support. And till now, I had to remove just one, in one case, the cement from its place. You can keep the cement. Lateral or even the second metatarsal. Second or any metatarsal, you can put it when you excise like the totality of the metatarsal, including P1, for example, and you are leaving P2 and P3, you can put a cement, a longitudinal cement, you can shape it as a metatarsal, and you can put it in the void. And it gives you like local control of infection, and it gives you like support when you have other metatarsals, just neighboring ones. I keep the extensor, I keep the flexors.
Just one question.
Yeah.
Basically, when you used, before getting into this method, were you debriding and closing the wound after the gangrene, or you were keeping it open?
I close.
I think this is one of the issue, because when you have this differential diagnosis of gangrene, you have anaerobes. And sometimes when you go and debride, even though you are doing a lot of washing, you can't control everything. So what we started to do is, in these cases, we go for the first debridement, we keep the soft tissue open, we put some gauze, and then we return after 2 to 3 days. And this helped us avoid major amputations.
You are absolutely right, but the thing is, the wet gangrene that we are talking about is not anaerobic. We couldn't find any anaerobe in our all cultures. In fact, the term wet gangrene is just to mean infected necrosis. That's it. One. Second, for the debridement, yeah, it's important because wet gangrene, it's sometimes we think about just anaerobe. There were no single case where we could find anaerobe, and we are doing anaerobe culture for every case. We couldn't find any. This is one. Second, most of the additional surgeries and infections happened in the bone, not in the soft tissue. So reason why we are saying when you want to remove, go proximal. Even نحن وقت بلشنا فيها قلنا بنشوف الام ار اي سيجنال we go like proximal 1 centimeter. حسينا حالنا انه عم نعمل شيء واو and we are going beyond infection. In fact, it was not enough. Thank you. So now Dr. Ala Ai'i will talk about pes cavus. What is important to know?
So here again, we are in a very simple case. So in 10 minutes, we can't cover all the treatment and the etiology of pes cavus. So I'm going to go to the main things. We all know what does it mean. In the literature, you can see it under different names, but the result is still the same. What do we have? We have an abnormal high plantar longitudinal arch. It is always associated with other deformities like clawing of the toes, hindfoot virus, contracture of the plantar fascia, co-cup deformity of the greater toe, and we have a shortening of the medial columns. These aspects are very important in identifying them because the treatment will depend on each aspect of these deformations. So these are some examples. And what is important to see that the hindfoot varus is really driven. It's not the primary cause, it's a secondary cause due to the ridger plantar flexed first ray, which is driving the hindfoot. What is important to know is there is 3 types of pes cavus. The pes cavovarus, it is in neuromuscular disease. Here, the calcaneus is in varus position. The first metatarsal is plantar flexed, and we have claw-toe deformity. When we know that, keep that in mind because the treatment will depend on the origin of the deformation. The second one is like the pes calcaneovalgus. We have it in some kinds of paralysis of the triceps surae, and here the calcaneus is dorsiflexed. It's neutral, it's not in varus, and the forefoot is plantar flexed. So when we have to address the correction, we don't have to do any lateralization of the calcaneus itself. And the pes cavus, the third type, here the calcaneus is in an anatomical position, but we have a very high arch, and here again, the deformity is in the midfoot. When we keep that in mind, the etiology is mainly some neurological disease or some sequela of poliomyelitis, of weakness of the calf musculature. Patients come mainly because they have pain, either on the lateral border of the foot or because the claw toes are becoming very difficult to fit in the shoes, and the symptoms will vary according to the stage. On the clinical examination, it's a main part of the diagnosis, and it will help us in the treatment. We have to see how the patient is in a lying position and in standing position to assess the deformities. We have to make a neurological exam to see if we have some motor deficiency or if there is any spasticity, because this will affect the treatment. And we have to see the patient walking on and gumming on. Normally, we try to ask him if he can tiptoes, then we can see the reductibility of the hindfoot or on his heels. And we're going to assess what we call later on the Coleman test. Everybody heard about it. We put just a piece of wood and we can assess the reductibility of the hindfoot varus. Why it is important? Because this will give us in the classification to see if it's a flexible cavovarus foot or a rigid one, and the treatment will be completely different in these cases. We do X-rays, standing, lateral, standing AP, and we try to understand and to calculate some angles. There is a lot of angles, but all of the one that is very indicative is the Mayari line that is continuous for the first metatarsal with the talus, and then we can see in this case that it's like a pointed head towards the dorsal aspect. And on the AP, we can see if we have any, the talocalcaneal angle to see if there is any deviation. So what we have as a problem list in each case is like we have pain that is limiting the walking, the stiffness that will lead to gait deviation if it is stiff, the lateral foot pain, patient cannot walk and put shoes on, and the restricted range of motion. And our aim is like to reduce the pain, to increase the range of motion, to reduce the stiffness, and to reduce the muscle tightness. And this is all to reach the final goal to allow the patient to ambulate without symptoms. We always start with physiotherapy management, unless for rigid spastic cases, and then we can equip the patient with some orthopedic insoles, orthopedic special foots, where they try to correct the varus of the hind foot and to avoid the friction in the claw toes and to work on the spasticity of the plantar fascia. If it does not work and we have some instability of the ankle, we will go for the surgical treatment. And here again, it will depend on the degree of the lesion. If we have a first degree, we will try to correct only on bone transfer, so, muscle transfer. We will not touch the bone and we will not do any fusion. And we have to follow up the patient to see if this is enough. In second degree, we have to make a release of the plantar fascia. We as orthopedic surgeons, we are always afraid to get a decompensated flat foot, but in this case, the medial column is too short, it won't happen. And we can do, again, some tendon transfers. In the third degree, we have maybe to combine some soft tissue operations associated to bony operations where we can do an osteotomy of the tarsus, or we can take off some of the midfoot in order to correct this plantar flexed midfoot and to put it in normal. And what is helping us now is that we can use some PSE guides to calculate the correction and to make the cuts at the proper level, because it's always difficult to estimate how much you want to cut when you are intraoperatively, and we associate to that a Dwyer's calcaneal osteotomy. In the fourth degree or in fifth degree of varus, where we have some rigidity and painful foot, here the soft tissue approach itself alone is not sufficient, and we will go to arthrodesis of, there are several types of arthrodesis. Either we go for a done triple arthrodesis or a Lambriduni arthrodesis, and this is, I'm not going to detail the technical notes about that. So what is important to know when you see a cavus foot is to identify which type it is, to do a thorough clinical examination to see if there is the spasticity, if the hind foot is reducible, and then we can planify what would be the treatment of this complex pathology. Thank you.
Thank you very much, Alain. It's a nice overview about an interesting but rare topic that is not often encountered in our clinical practice. Any question?
This is a very difficult.
Yes.
Timing of the surgery, because common cavus is surgical pescavus and progressive disease. However, think that it will progress again. So the timing, what is?
I mean, as you said, it's a neurological disease that we diagnose when the patient is still an infant. And then we will start to give him some insoles, some shoes. And we will keep on with that to the maximum that we can tolerate. But once we have the fixed deformity and the patient is in varus and he's walking on the lateral border, in that case, we know that if we, and he will reach approximately more than around 20, 25 years of age. If you do that, we try to do correction osteotomies before getting into arthrodesis of the tibiotalar joint or those. We can go and do some arthrodesis and correction on the subtalar joint by keeping the ankle free. Because we know, as you said, that in 20 years, we might have to redo again something. And these patients, if they had already some tendon release or tendon transfer when they were between 6 and 15 years of old and lengthening of the Achilles tendon, you will find yourself with a lot of fibrosis. So you can't identify all the structures. And this is why the idea is like to keep them as much as possible with conservative treatment. And when we do the treatment, we will do it à la carte, according to the deformity. And we go and we address only the symptoms. If he has pain on the lateral side, the idea is like to make it more in pronation. If he has clotos, we will address the clotos. We cannot dream of achieving a very nice foot correction in this kind of population. We have to accept these limitations and accompany them.
I think it's this is especially for the junior surgeons and residents. It's very important what Dr. Alain now have said about it. Just go à la carte when you have a deformity. Don't overdo. So wait until finally you have a totally like fixed foot to go for fusion. You can even do a dorsal closed wedge osteotomy of first metatarsal when you have the summit near the chopard or the wrist front joint. It's just an osteotomy to reduce the plantar flexion of the first metatarsal to alleviate the symptoms. Any other question? Remember that when you have a pes cavus, same for the junior orthopedics and residents, when you have a pes cavus, it's quite nearly always a neurological problem. So this, remember it, and sometimes it's very, very subtle. There is no big deformity, and there is no other thing. Reason why you send everybody to your colleague, your neuro colleague, to make a total assessment, but sometimes that would be the only sign or symptoms in a Charcot tooth Marie. Now I will ask Dr. Khalil to talk about talus fractures, types, and surgical options.
Hello, good morning. My topic for today is about talus fractures, types, and surgical options. Allow me to start this talk by a message to our dear colleague, Dr. George Abirad, who passed away 1 month ago. Dr. Abirad was a pioneer in foot and ankle surgery. He passed 4 decades in advancing and marking the specialty in Lebanon. We all remember him as a passionate foot and ankle surgeon and a caring colleague. May his soul rest in peace, and condolences to his family. So when we talk about the talus and the talar fracture, we have 2 main anatomical facts that we should remember. First of all, the talus is a bone covered by a rate of 60% by cartilage. And the second thing to remember is the blood supply. For the neck, and the head of the talus, we have a dual blood supply with the peroneal branches and the anterior tibial branches, while for the body, we have one main blood supply coming from the posterior tibial artery. And this is a very important thing to remember while operating on the talus. The mechanism of injury: usually talar fractures occur with a high energy trauma, either a motor vehicle accident or fall from heights. If we have a hyperdorsiflexion, usually we have a neck fracture. If we have eversion or inversion, usually we have process fractures, in addition to body fractures, depending on the severity of the trauma. The Hawkins classification is the best classification to describe the talus fractures because it associates the type of fracture to the rate of avascular necrosis, the main complication of talar fractures. Type 1, we have a non-displaced talus fracture associated with up to 13% rate of avascular necrosis. Type 2, we have associated subtalar dislocation with up to 50% avascular necrosis. Type 3, we have ankle and subtalar dislocation with up to 100% risk of AVN. And type 4, we have talonavicular dislocation with up to 100% risk of AVN. For the clinical presentation, usually patient arrive to the emergency room with pain of the affected limb, swelling, deformity, and inability to bear weight on this limb. We start the investigations with regular X-rays. Later on, we do CT for better details. And after that, we can go for MRI if we want to evaluate for any osteonecrosis. For the treatment, first we have the non-surgical treatment that is applied in cases of non-displaced fractures or less than 2 millimeters of displacement. This is the importance of the cartilaginous coverage, 60%. So we treat the talus as an articular bone. If we have 2 millimeters of displacement or more, we need to operate. For the surgical management, what is most important is to understand the approaches to the talus. We have the anterolateral approach, which is the safest one, but it is not enough to treat complex fractures. We have the anteromedial approach. Here we should take care for the main blood supply of the talar body, and usually it is not enough also, so most of the time we need to combine the anterolateral and the anteromedial approaches. We can use the posteromedial and posterolateral approaches in cases of posterior process fractures or posterior body fractures. And sometimes we need to do osteotomies, medial or lateral malleolar osteotomies, to have a wider view on the talus. For the fixation technique, we can go for screw fixation. What is important here is to have the screw perpendicular as much as possible to the fracture. Here we are talking about simple fractures, and not to cross the two screws at the fracture site. And in more complicated cases, as we talked previously, we can go for a dual approach to treat it by medial and lateral fixation. And here we have to stress on the point that we almost always start with the lateral fixation to disimpact the neck and regain the length of the talus. And after that, we do the medial fixation, where we usually have severe comminution, and sometimes we need to augment this by adding bone graft. And for the fixation, we can use plates, we can use screws, whatever we find possible during the surgery. For the post-operative care, we can go for non-weight bearing from 6 to 12 months, depending on the evolution. And after that, we start progressive weight bearing, but we need to start the physiotherapy as soon as possible, as the pain allows, to avoid stiffness. For the complications, the most important one is the avascular necrosis, the osteoarthritis, the malunion of the fracture, and the infection. Thank you.
Thank you, Khalil, for this nice presentation. These are very rare fractures. ما بعرف واحد بيقطع السنة سنتين تيشوف واحدة منهم. It's not really and difficult to treat, and it could end up with complications. Any question from the audience? Did anyone happen to put screws from posterior to anterior in these fractures?
Yes, we did it. We go because they had an associated posterior process fracture. So we went arthroscopically posteriorly, we debrided that, and we put the K-wire from posterior to anterior.
But it could be more easy sometimes to put it posterior to anterior because you are more perpendicular to the line of fracture.
And in cases of posterior process and posterior body fractures, it is easier to put it posterior to anterior.
Exactly, especially mechanically it's stronger because you are more perpendicular also to the fracture. True. Anybody had put like plates on a talus fracture?
Hello.
We started doing for complex fractures the dual approach. And the medial approach is a little bit tricky because you are working in a very narrow space. But if you understand the anatomy and you respect it, and you have to go with the mini fragment plates. It's always very small, but it's very elegant to do it.
So you put plates on both sides? You didn't encounter any higher risk of avascular necrosis?
In fact, it's not the surgical approach that gives the risk of avascular necrosis. It's the complexity of the fracture. So when you don't...
But it can enhance it.
If you don't respect the dissection, if you go and you do the dissection properly, and we do that probably like 7 to 10 days after the accident, so we can have a very smooth skin where you have the wrinkles and the situation is really well defined. And this in the literature shows that it is more stable and it gives better result and less avascular necrosis when you put the dual plates.
That's nice. Any question? Yeah.
To stay with the same line of a question, Ma Cesar, has anybody had to use bone graft?
In comminuted fractures, severely comminuted fractures, like in calcaneal fractures, we sometimes use bone grafts.
I did it once only in my life. And it was not that much wow.
And?
To incorporate it. I did it once. Yeah. And it was not that much, wonderful to put it because it will change the anatomy. You need to put really the
size,
exact size of the talus.
But when we have severe comminution and loss of cartilage, so we need to...
I know, we need to do it, but you are putting graft without cartilage.
Yes.
So, yes, it's not that much...
To maintain the length, maybe.
If you want satisfying for the surgeon.
And sometimes there is an impaction, comminution, and the length, we cannot judge it really.
Usually we can rely on the lateral aspect, usually, unless we have a burst fracture, I don't know. But if we have an intact lateral aspect, we disimpact the neck and we put our plate.
Thank you.
I used twice the ACL guide to put screws, anterior-posterior screws, and these are for simple, minimally displaced fracture of the talus. It could be a very useful way to put it. Minimally invasive, but it's minimally displaced, usually, these kind of fractures. So the ACL guide could help you to put the wire and the screw. Any other questions?
Thank you.
Thank you,
Thank you.
Khalil. Thank you. Sorry.
Yeah, في coffee break.
إيه، في
Yeah,
الكافي بريك
but
بعد
for
7 دقائق يعني
10 minutes.
Yeah.
Thank you.
Thank you.
Check, check, check. Check, check. Check one. Hey.
Test. Test. Test.
Good afternoon. We will begin our last session for this day. It will be about hand surgery. We will discuss several topics, and we will begin with Dr. Ramzi Msharrafiyi. He will be speaking about ulnar-sided wrist pain after distal radius fracture. Thank you, Ramzi.
Thank you, Dr. Abia. Good afternoon, everybody. As Professor Abiyad said, this session will be mainly about common topics in hand surgery, and we thought that this year we'll talk about few pathologies that we rarely touch base on. First topic we'll be talking about is the persistent ulnar-sided wrist pain after distal radius fracture. As you know, ulnar-sided wrist pain is a common complaint that contains a diagnostic challenge for hand surgeons. Basically, because of the small and complex anatomic structures on the ulnar side of the wrist and the possible pathologies that can lead to ulnar-sided pain. Usually, a proper history and a physical exam can really start differentiating between these pathologies that often overlap. Pain may derive itself also from the forearm and the carpal bones. It can be secondary to the triangular fibrocartilage complex, to the ligaments in the hand and possible tears, tendinitis, to vascular pathology, osteoarthritis, and different other pathologies, including nerve compression. As we've said, the distal radius fracture is a very common fracture. And it's among the most common injuries, and nowadays the surgeries that we are doing over the distal radius leave us with patients sometimes, even with the best fixation devices, many patients will continue to complain about ulnar-sided wrist pain. And these are usually transient, but some people will have persistent pain that will warrant further workup. Usually, if patients present with ulnar wrist-sided pain, they can have a drastic effect on their recovery and the patient satisfaction. And even if you do the most beautiful reduction, people complain of ulnar-sided wrist pain, they would really be dissatisfied. The three major causes that we're going to talk about are the malunion, the triangular fibrocartilage complex injury, and the ulnar styloid non-union. And each procedure has a different biomechanical disturbance, and recognizing these distinctions is really crucial. As you know, we've presented this maybe last year about ulnar-sided wrist pain in general. The symptoms are usually overlapping, and there are plenty of structures that can cause such pathologies. Starting with tendons, with ligaments, as we said, the triangular fibrocartilage complex, the bone joints itself, etc. And the diagnosis can be challenging because, as we said, the symptoms can often overlap, and the clinical tests and the imaging that guide us are plenty, and here is a list of the provocative tests that you can do to distinguish between these pathologies, but the wrist arthroscopy remains the gold standard, both as a diagnostic and a therapeutic modality. Malunion changes the load distribution across the wrist. On the other hand, the triangular fibrocartilage injury compromises the joint stability, and the styloid non-union may cause symptoms that are related if the distal radioulnar joint is also unstable. And understanding these mechanisms help us tailor the intervention. Now, the natural course of ulnar-sided wrist pain is usually very mild, and it can decrease over the years. And usually it decreases with time. If you are patient enough, if your patient can wait, usually it will take around 12 months and self-limited. And usually you resort to conservative treatment, and you only intervene if really it persists for a long period of time or if it's really severe. I've reviewed the literature. There were 2 level 2 prospective studies, 6 level 3 retrospective studies, and 1 level 4 retrospective study. And these were identified and assessed, which talked about the ulnar-sided wrist pain. And here is the list of these studies that I went through. And the evidence summary in the literature shows Kim in 2016, he talked about that, as we said, pain improves with time. Cheng described 4 etiologies, and he described the targeted surgery towards these etiologies. And Wanda confirmed that osteotomy is very effective, while Denise and Wishfeld suggested that restraint should be performed by the surgeon when lesions are stable and asymptomatic. I'm going to present 3 cases which describe the different pathologies. The first case is about the palmar malunion, the second case about a triangular fibrocartilage tear, and the third is about styloid non-union. And the message is that personalized treatment based on the pathology usually provide a durable relief. The first case is a 76-year-old male, right-handed female, who had a left distal radius fracture. She was immobilized for 4 weeks in a cast. She presented to the clinic 3 months after removing her cast with a swollen, deformed left wrist, complaining of persistent ulnar-sided wrist pain with a restricted range of motion and a decreased grip strength. Now, the radiographs showed radial shortening, as you might see, with ulnar variance, which was around 3.5 millimeters. Radial inclination was 5 degrees, and the palmar tilt was 35 degrees. So what do you think is the most effective approach for the management of the ulnar wrist pain for this patient? The patient mechanics were altered. So an open wedge osteotomy was carried out from the palmar side and fixed with the palmar locking plate. The bone graft was filled, the bone defect was filled with a bone graft, synthetic bone graft, and an intra-articular arthroscopic debridement of the triangular fibrous tissues, proliferation, and the TFCC flap were performed simultaneously. Range of motion exercises were introduced directly post-op, and 2.5 months after surgery, radiographs showed complete union. The hardware was removed 16 months after surgery, and the patient's symptoms of ulnar-sided wrist pain was completely relieved. Range of motion was almost normal, and the grip strength was comparable to the contralateral side. So by addressing the abnormal mechanics in this first case, we were able to get rid of the ulnar-sided wrist pain. Now, the second case is a 56-year-old right-handed female also, who had a right distal radius fracture. She was also casted for 4 weeks. She healed with normal range of alignment. The radial inclination, the palmar tilt, and the ulnar variance were within normal. However, she had persistent ulnar-sided pain for around 10 months and decreased grip strength. Further assessment showed that despite a proper alignment of the distal radius, an MRI showed a slit tear of the triangular fibrocartilage. And at this stage, I think the best way to manage this persistent ulnar wrist pain was to do a diagnostic arthroscopy and at the same time to treat the triangular fibrocartilage flap tear, the slit tear, and the associated tenosynovitis. So the debridement was carried out and the patient had relief of symptoms. The third case is a young male, 28-year-old right-handed male who had a twisting injury to the wrist several days prior to presentation. Previous medical history revealed that at the age of 13 years, the patient had a distal radius fracture which was casted for 4 weeks. Sorry for the quality of the picture. Okay. And the patient has ulnar-sided wrist pain and slack sensation of the ulnar head during forearm rotation. As you can see, there is prominence of the ulnar styloid. The patient was treated conservatively with a removable wrist splint for around 4 months. However, he failed this conservative treatment and the ulnar-sided wrist pain persisted. So what do you think the best management is? Especially that the radiograph showed a persistent non-union, which is attributed to the fall at the age of 13 years. And this ulnar head instability was obvious when examined under anesthesia. And the patient was planned for surgery. Non-union was refreshed. We did one case last week, similar case, me and Dr. Abdel Noor, and you can see immediate restoration of wrist stability. You have to debride the fibrous non-union properly. Sometimes you put a bone graft, you can harvest it from the distal radius or from the olecranon, and the ulnar head instability usually disappears after you apply whether a tension band or a hook plate at the distal radius. Arthroscopy showed the triangular fibrocartilage fovea, which was elongated before the surgery. After the surgery, it is tight. And 1 year after surgery, range of motion and function of the wrist were normal, and the ulnar-sided wrist pain has resolved. So these three cases demonstrate the three different types of pathologies that are the most common pathologies that cause a persistent ulnar-sided wrist pain following distal radius fracture. Whether it's malunion, and you can approach a palmar and a dorsal angulation by an open wedge, the studies have showed that even a closed wedge can be used. It depends on the ulnar variance. The triangular fibrocartilage injury can be diagnosed and managed arthroscopically, and the ulnar non-union only if associated with instability. So the diagnostic algorithm, you assess the alignment by X-ray. If normal, you move towards an MRI for TFCC or a lunotriquetral tear. If inconclusive, you do your arthroscopy. And if there is persistent pain and instability, you do surgery. For malunion, as I mentioned, you do a corrective osteotomy. For the TFCC tear, debridement or foveal repair. Styloid non-union, you fix it only if unstable, and if it is stable, you excise it. Lunotriquetral ligament, debridement, pinning if symptomatic. Pearls, most of these pains resolve and improve on their own in a year's time. Arthroscopy can act both diagnostic and therapeutic, and restoring alignment restores the mechanics. Pitfalls: don't treat X-rays, treat patients, and only repair symptomatic lesions. In summary, ulnar-sided wrist pain after distal radius fractures is common but often self-limited. Main causes remain malunion, TFCC injury, and styloid non-union. MRI and arthroscopy guide the diagnosis, and you have to individualize a treatment which restores function. Thank you for your attention.
Thanks, Dr. Msharrafi, for this beautiful talk.
أنا بقيت ال 25 دقيقة باخدها بآخر.
Do we have any question from the audience? Is there any question? No question. I will ask you a question, please. Do you have a clear-cut position to take in front of ulnar styloid avulsion associated with those distal radial fracture? Because usually it's frequent. Most of the time it's the tip. Sometimes it's avulsed from the base. And at the end of the surgery, we test the distal radio-ulnar joint. It's stable. But to prevent those scenarios you showed us, is there any clear-cut decision to take during the surgery?
Yes.
Should we fix them immediately?
No, you've already answered your question. You said if it's stable, you don't do anything.
But sometimes
you test it. Not all of us test it. This is the point. A lot of people don't test for the instability of the distal radio-ulnar joint at the end of the procedure. I think if the fragment is small and the distal radio-ulnar joint is really stable, you don't need to do anything. If there is any discomfort, it will be self-limiting. But the trick is when you have instability and you leave it. This is when you get into trouble.
Because sometimes, even if it's stable, it will take a long time for the pain to relieve.
This is what
I'm asking myself, should I have done something for this don't
Usually
know.
in the literature, as I've, I've realized when you go over the 9 studies that we went through, most of these are self-limiting if it is a stable tear, unless it's associated with a triangular fibrocartilage slit tear, But most are self-limited. But the whole point is really to test for instability at the end of the procedure.
Another question. Do you recommend wrist arthroscopy at the end of the procedure to see if there is associated TFCC or other ligament tear?
Not routinely, to be honest. We're not doing it routinely. If we have the luxury to do it, why not? But even, when we started doing open reductions with wrist arthroscopic assisted reductions, intra-articular reductions, we faced a lot of problems with the insurance companies. So I don't do it myself routinely. Dr. Wissam?
Thank you for this complete presentation. So I think the problem of the tip of the ulna styloid is not important. So we can leave this. What is important in the reduction of the fracture is the anatomical alignment and the pronosupination, control the pronosupination and the stability. So the pain in this region after a distal radial fracture is especially the impingement. So this is important to reduce your radius. The second thing is the age of the patient. So when you have 76, 78, it's not important even if you have impingement, because it will resolve automatically because they are not so demanding patients. But the stability is very, very important, and the reduction. And in your first cases, I think the problem was it was a operation indication, the first X-ray, because we have a shift of the hand. You see the hand, the axis of the hand is outside the radius line. So this is an indication from the beginning. And this is a fault from the beginning.
Yeah, if you want to dig into most of these, the mechanics, when they're altered, it affects even not only the distal radioulnar joint, the ulnar wrist pain, but also the mechanics of the wrist bones itself. As Dr. Azzi mentioned, if you look at this X-ray, look at the lateral, if you draw a line through the capitate and the lunate, it doesn't coincide. It's volar to the distal radius, and this is like a Z deformity, and you'll end up with future problems, even if you don't have distal ulnar sided wrist pain. There is one thing that I wanted to mention, that even, in the past, we used to notice when somebody presents to you, an elderly lady with a prominent distal ulna, and she's complaining about it, and we used to do a lot of resection, Darax procedures. I think this is hiding behind our, our fingers when we really treat the secondary effect rather than the primary pathology. So you have to restore the proper mechanics. Always at the end of the procedure, people who work with me, they've noticed that we test the pronation supination, we test the stability, and we make sure that you don't have a clunk at the end of the procedure and impingement over the ulnar aspect also. Thank you very much.
Thank you. Thank you, Dr. Ramzi. One question, please, Professor Ramzi. We noticed from these 3 cases that all the patients were treated conservatively by cast fixation, okay? And the time of fixation was 4 weeks. Do you think, concerning the result, for example, malunion of distal radius and malunion of styloid process, and even TFCC, of course, it is done by the shortening of the timing of conservation? Because if we start to treat it, at least 6 weeks or 8 weeks, okay? Do you think it is a problem here?
I want to answer by saying no, it's not a problem. And the reason why I'm laughing, because the seniors in my department, they're writing a paper now about the 6 weeks myth, about everything in orthopedics is about 6 weeks. 6 weeks of cast, 6 weeks of immobilization after flexor tendon, 6 weeks for DVT prophylaxis. And definitely, if we come back to your question, it has nothing to do really with the timing, because as you know, the collapse, if it were to happen, it will happen at the beginning. So the immobilization in itself for a longer period of time, it's not going to really get rid of the collapse if it were to happen. And the fracture, if it's unstable, it's going to be unstable whether you immobilize it for 4 or to 6 weeks. So definitely, the fractures of the distal radius, it's a very big chapter. And if you were to review the literature with all honesty and see who does better, patients who are treated conservatively, patients who are treated with the locking volar plates or with the percutaneous spinning, with the Kopunji technique, etc., you can find papers that will argue that you get the same results at the end of the day. If the mechanics are really restored and you still end up with ulnar wrist pain, I think this is the problem. But a lot of them are self-limited, even if they collapse.
I have to say something. Plaster is disaster. So 6 weeks is enough for everything. And even after the, when we operate these patients, so in some school tried to put the cast for 1 week only, even nothing. But we thought that the cast is important for 3 weeks because we have always something on the TFCC or on the tips of the styloid. But more than 6 weeks is enough. We do everything to avoid the CRPS, and we have to try to keep moving this patient rapidly. Voilà. Okay, we will move on, and I will present Dr. Hashim Abdul-Noor, who will ask, oh, Hisham, sorry, he will talk about replantation, how to proceed, and when to consider. Thank you.
Good afternoon. هذه ما عندك شيء تقوله خلاص بدي ضل هون يعني. So I'll be presenting. No, it's okay. I'll be presenting a topic that most of you maybe don't like or run away from. Mainly, it's how to proceed and when to consider replanting a finger, hand, or any part of the upper limb, or going directly for amputation. So a small outline, we'll talk about a small introduction, the indications for replantation, contraindications, preoperative consideration, surgical priorities, principles and intraoperative consideration, how to go post-operatively in rehab and monitoring complications and outcome measures. So basically, it all starts with a phone call. You get a phone call telling you that, please, we have an amputated finger or hand. So what are the next steps to be done? So what are the first questions that you have to ask the person who is calling? So the main questions are the age group, the nominant, and how, since when this happened. So this is why these three questions give you an idea if there is an indication or there is an indication for replantation or not. So what are the main indications for replantation? Mainly it's the thumb amputations, multiple digit amputations, hand or wrist level injuries, pediatric cases of course, and the viability of the amputated part, the ischemia time as we said, the mechanism of injury, and other key considerations like patient's comorbidities. Contraindications for replantations mainly are prolonged warm ischemia time over 12 hours, severe crush or avulsion injuries with non-salvageable tissues, life-threatening polytraumas where there are more important stuff to manage, and patients with poor compliance or significant medical comorbidities that would cause your replantation to fail afterwards. So mainly there are 40% higher survival in 0 to 6 hours replantation than 6 to 12 hours. I'm talking about the warm ischemia time. So going between 0 and 6 hours, you have a 40% higher success rate than 6 to 12 hours. So the earlier, the better. Because previously, by the books, we used to say it's 0 to 6 hours. Before 6 hours, you should replant. Now, the latest updates mainly say cold ischemia time or warm ischemia time. So the warm ischemia time should be less than 12 hours, better 0 to 6 hours. If it's cold ischemia time, it's less than 24 hours. So for sure, it's the earlier is the better. So what are the preoperative considerations that should be done? So basically, you should stabilize your patient, give a tetanus prophylaxis, give broad-spectrum antibiotics. You should make sure that the part or the amputated part is preserved in a saline moisture goes and not directly in the normal saline or not directly in the ice, because this is the main question you have to ask before telling the patient to come to your facility. How is the amputated part preserved? Because if it was preserved in a wrong fashion, there is no room for trial even for replantation. And for sure, urgent planning with the anesthesia and the microsurgical team. So whenever you get the call, this starts the cycle. You go for one call, and then you start your calls to get the whole team ready, basically the anesthesia and the OR team, because to be on the right track. So what are the surgical priorities? We start typically mainly by the bone, fixing the bone, tendons, arteries, and venous anastomosis to restore the vascularity. At the end, the nerves, and then the skin closure. So for sure, the artery is prioritized to reestablish the perfusion, followed by at least 2 veins. So why are we saying bone shortening? Because sometimes depends for sure on the mode of injury, how crushed the distal part is, and how difficult your reimplantation is, and how difficult your anastomosis are. So this is why sometimes you are obliged to do some bone shortening to have your anastomosis less tight or easier to fix. So as we said, minimizing the tension, it is usually done with K-wires or mini plates. Even if these are considered open fractures, as I have learned and how I learned during my fellowships, the hand rarely infects. It is highly vascularized. If you wash very well, you can even put mini plates on unstable fractures when it is indicated. So you're not always obliged to put K-wires. For sure, it is better to put K-wires, but you can put even mini plates in reimplantations. Okay, so mainly whenever we have to make sure not to damage soft tissues, your entry or exit points shish kebab techniques are very good, are mainly used when starting your first steps. In articular fractures, you should know your angulations if you're going for fusion directly, which articular surface to fuse, at what angle to fuse for further post-operative care. So the goal is stable alignment without impeding subsequent tissue reconstruction. So you have to think about your arteries, your tendons, your ligaments, and your nerves at the end. And if you want to do any transpositions, you have to take the decision now. So every step has its own decision. If you want to transpose an artery or the vein from dorsal to voral or a nerve, you should take the decision now and not keep it to the end of your. The arthrodesis angles. So these are, you should know directly if you want to arthrodese directly during reimplantation. So mainly these are the angles, the metacarpophalangeal joints from the second to the fifth. You go 5 degrees. This is the anatomical position, and the IP joints. So mainly the IP are at 0 degrees. The PIP 40, 45, 50, and 55. And the thumb is the most important. So it's 15 at the metacarpophalangeal joint and 10 in the interphalangeal. What about the tendon repairs? Every one of us has his own tendon repair techniques or suture techniques. The most important thing is to have a 4-brand or a 6-brand technique for flexors, and mainly the modified or the Kessler technique for the extensor apparatus. Peritendinous sutures are important, especially in the flexors, because it helps in the gliding and the sliding inside the pulleys. Even at the extensor part, peritendinous sutures are important. I usually use PDS sutures so these are resorbable sutures. I've been in schools where they use non-resorbable sutures, maybe nylon or fiber wire sutures or fiber loops, 4O. I usually had never problems with the PDS sutures when when fixing flexors. So what about the vascular anastomosis? So as we said, we start with the arteries. So mainly you should be a team of 2. It helps in the replant. One explores the distal part or the finger, and the other explores the proximal part. You should look for your arteries because mainly depending on the mode of injury, it could be difficult to find the arteries, if it's avulsed, if it's tortuous, if it's bleeding or not. So you have to be on-off with your tourniquet. Look for the arteries, see if they are proper for, or they can be salvaged or anastomosed. See if there is any intimal damage, if you need to have clear cuts, if it's enough for the anastomosis, or you need to have a venous graft. So these are steps you have to think about directly while looking into your structures and exploring your distal and proximal part. So what about the venous outflow? As we said, we need for every finger, we need around 2 veins to anastomose. Mainly, as I've learned, for every artery, you need 2 veins. So basically, you need 4. If you do both digits, you need 4 veins. This is nearly impossible. So if you do 2 veins, it's perfect. So it is the veins are the key for survival for the replant, because most of your problems is due to congestion and to the venous outflow. So it is more technically demanding. Usually you should remove your tourniquet while doing the veins, because you need the blood flow in the veins to dilate your veins and take your sutures, mainly with 10-0 or 9-0 sutures. If we have any post-operative problems with the veins, leech therapy can be temporarily used. I don't know if some of you have leech therapy here in your facilities, but it can be useful. So we should be, it is more difficult to treat venous congestion than arterial congestion, depending on the cause for sure, arterial thrombosis, sorry. This is why you should manage your post-operative anticoagulation depending on how good your anastomoses are and the quality of injury. So at the end, you finish your arteries, you finished your veins, you go now for the tendons. So for the nerves, mainly it is coaptation of the nerves. You do your 3 to 4 9-0 sutures. The earlier nerve repair improves the sensory recovery and functional outcomes, especially in the thumb and in multiple digit reimplantation. So your sutures should be epiperineural and not inside the fascicles. They should be not that tight, just continuous enough to promote healing. I don't know if some of you put bioglue around, but it's costly here in our country. So what about skin closure? One of the most important steps. So every step is very important, but this is the last step that could cause all the other steps to failure. So if you close very tightly over your veins, you could collapse your veins. So it should be tension-free. When primary closure is not feasible, go for grafts, flaps, such as cross finger, groins, anything can be used. The most important thing, don't keep your anastomose structures uncovered. Keep other tendons, anything uncovered, but not your anastomose structures. So it is vital for the repaired anastomose structures and important not to have any dryness and cause any thrombosis or venous congestion. So this is a 3-finger reimplantation. So post-operative monitoring and perfusion checks are vital in the first 48 or 72 hours. If you see well in the third finger, in the fourth finger, sorry. كيف نرجع نمشيها هذه؟ So this is a 3-finger implantation, sorry. The third, the fourth, and the thumb. If you see the fourth finger, it's more congested than the others. And with a faster capillary refill, this is the fifth with a pull-out. So the fourth, you should always be aware when there are faster capillary refills. This is a sign of venous congestion. You should start with removing the bandage, because it might be that simple that the bandage is what compressing your venous outflow and your collapsed veins. One of the other monitoring is to monitor the other monitoring post-operatively is the saturation. Usually I use the saturation for PEDS or neonatal bands. You should compare the saturations between all fingers or with the contralateral fingers. You should keep your room warm, not just the hand warm. He should have systemic. You should have systemic warmness, not to have vasoconstriction of the vessels. Take care of your capillary refill for sure, the temperature and the turgor. So early detection of arterial insufficiency or venous congestion is very crucial, and you should go back to the OR directly as long as you think that it is salvageable, or you took the chance at first and tried it and it was just tight that you go for amputation or reimplantation. So whenever you see that there's a chance that you might save it, you should go back directly to the OR. So what are common complications? We have early and late complications. So the early complications are the thrombosis, the infection, and the necrosis. Later complications, so joint stiffness because of prolonged fixation or immobilization with a cast, tendon adhesions, cold intolerance, neuroma formation. So regular follow-up and therapy are the key to managing these challenges. You should tell your patient and to keep in mind before and after the surgery that he might need several operations afterwards, either to do any tendon transplants or tenolysis or any non-union repair. So he has to be aware of all that he might need several surgeries afterwards. So rehabilitation and functional recovery, I start mainly around 2 weeks by the books, and the updates say that you should start within 7 to 10 days post-op. I think it should depend on what is the type of injury, how difficult was the reimplantation, and how damaged were your arteries, if it was a crush, avulsion, or what type of injury. So the therapist should focus on the tendon gliding, joint mobility for sure, and preventing adhesions. Patient motivation is crucial because the patient, mainly these are low IQ patients, they are manual workers. This is a patient I did recently. This is at 8 weeks. No, this was at 3 weeks. He is carpenter. So I spent around 8 hours reimplanting 3 digits, and now the only thing he asks if it would go back to 100% normal and if he can smoke. So these are the type of questions that you get. They should be aware. You should motivate the patients to tell them that the most important thing post-op is to have a functional hand, enough to have a near normal lifestyle afterwards. So we can use also the recent AI therapy with VR trainings to help in post-operative management. The only problem is that the part of the patients that are manual workers don't have access to this in our country. So what about the outcomes and the success rate? So the highest success rates are in thumb and multiple digit replantation. So survival depends on the ischemia time, the mechanism of injury, and the surgical technique. Function often correlates with early mobilization and compliance. For sure, every case is a case by itself, so there is no case like the other. Every patient should be treated individually. You cannot treat all amputations in a systemic way. As we said about the warm and the cold ischemia time, the cold ischemia less than 24 hours, the earlier the better. These are the latest updates. For sure, it depends on the country you are in. So when I was in Canada, it's around minus 20 degrees outside, so it can take up to 24 hours. Here, it's not the same. So 24 hours for cold ischemia time. Warm ischemia time, less than 12 hours for sure. 0 to 6 hours is better. Proximal limbs, mainly hand, wrist, and the forearm, should be less than 6 hours. It's better outcome when going less than 6 hours. So the part should be, you should emphasize that it is saline soaked gauze and put in ice during transfer, and not directly with the ice or not directly with the normal saline. So what about the role of the microsurgical skills? It's very essential in vessels and nerve repair. Usually use your microscope, 9-10-0 sutures. Atraumatic techniques should be used for sure. So success depends on the surgical experience also and the facility capability. You should have a good microscope, good conditions of working. So mainly the arterial repair. The only instrument that can go into your artery is the vessel dilator and nothing else. While anastomosing, micro dissectors should not go into the artery. There is one and only instrument that goes into the artery to dilate or to clean the intima is the micro dissector. You should circumcise your artery very well, remove your adventitia, take good sutures, take tension-free stay sutures. Depends on how many sutures, at what level your amputation is. You go for 6 to 8 simple sutures. Be careful not to go with a back wall suture that closes over your artery and causes thrombosis. Okay. Complications and vascular failure, so arterial thrombosis and venous congestion early threats. Arterial problems go for pale, cool digits. Venous go for fast capillary refills and cyanosis and swelling. So immediate re-exploration may salvage the replant, as we said again, if you think you should intervene or not. Functional outcomes, it depends on the injury level, the age, the repair quality, and the rehab. Thumb replantation yield the most significant gains. Return of protective sensation and grasp strength are key benchmarks, as we said. So going back to the minimal functional and activity. So this is the 3 fingers. This is at 8 weeks of the 3 fingers. We have still some stiffness in the thumb, as we see, but the 3rd and the 4th digits are moving very well. I don't know if you sacrifice one of your tendons while suturing your tendons. I basically sacrifice the FDS. I do not suture both tendons. I try to do both digital, both pedicles, if feasible, for sure at the end. So I start with 1 pedicle in each digit. I have my perfusion and my arterial supply to each finger, and then go back afterwards for a second pedicle. I sacrifice the FDS just to have room for the FDP to glide and have the minimum functional outcome and best functional outcome in terms of range of motion. And the earlier, the better, as we said. So protocols, early range of motion should be initiated between day 3 and 5. For me, this is nearly impossible. These are latest updates by the books. Day 3 and 5, the patient is still in pain. The hand is still macerated. It is nearly impossible to start by day 3 and 5. Active motion begins around 3 weeks post-op. Yes, a certified therapist is the most important, and he should know the repair complexity, and the compliance of the patient is vital. Sometimes it's not that vital because this patient was not compliant and he removed the cast at 5 weeks. It can help in some cases, but I had a patient that had 4-finger implantation. He removed the cast at 9 days. He moved his fingers, and all fingers had venous problems, and we needed to re-amputate all 4 fingers. So compliance is vital. What about the psychological aspect of recovery? Patients often undergo psychological distress. Counseling and occupational therapy and peer support enhances the adaptation. Patient education before and after surgery is essential. So salvage versus replantation. Decision to replant versus amputate depends on the ischemia type and multiple factors that we talked about. Clean-cut thumb amputations in young patients are clear candidates. Pediatric patients are also clear candidates. Might cause disturbances, growth disturbances, and should require long-term monitoring. Secondary procedures after replant, we said we might need arthrodesis, stenolysis, grafting, or anything that improves our functional outcome and to correct any deformities. So we can measure our outcomes in multiple ways: the pinch, the grip, the range of motion, the sensation. So all of these should be monitored after our replantation. So the success in hand and finger replantation requires surgical precision, early rehab, and multidisciplinary care. Case selection is the key. You should know which patient to replant, which patient not to replant. Sometimes you don't have any option, so it depends. Every case is by its own. So restoring function and quality of life is the ultimate measure. So the take-home message is don't be afraid of failure. This is not a total hip replacement. You can have it. There are percentages of having failures. Don't think about your reputation. Think about the risk you are taking to try to save the amputated finger or limb. Thank you. So this was a fast presentation of a very, very huge topic.
Hisham, you said you always try to suture both pedicles, arteries.
I usually didn't before, but here in Lebanon, yes.
Because aren't you afraid about congestion? Because usually it's not hard to do the artery, but the problem is the veins on the dorsal side, and usually we are not able to do more than two. I personally do one artery, and I've never tried to do the other pedicle, fearing of congestion and ischemia due to the congestion.
Honestly, I think it depends on every case. If the comorbidities are very important. If he's a smoker, diabetic, or any other risk factors for arterial thrombosis, I honestly started doing both. Before, I've never did both, even so to say, for the sake of time at first, because doing both on multiple digits is heavy. With respect to the congestion, you can keep it to bleed as much as you can. You can lower your hemoglobin level up to 7 while bleeding. You are not always obliged to coater all the vessels on the dorsal aspect. Some articles described keeping the patient to bleed just a few days at first to have a good outflow. With the leech therapy, because the problem is the equivalence between the arterial and the venous inflow, outflow. There's no clear-cut answer for this. It depends on the patient, the quality of your suture, and the quality of your arteries, because most of the patients are not clear-cut amputations. While I was in Canada, it was always clear cut because it was with a déneigeuse, the thing. It just it's always clear cut in different. Here it's not the same. So you have crush injuries, you have avulsion injuries. Your arterial anastomosis does not have the same quality. You have intimal damage. I basically give even aspirin and Xarelto post-op. If I did any vein grafting for arterial anastomosis, or if I had severe intimal damage, I give 5 days of continuous heparin with a PTT of 50 to 70, with 4 hours continuous monitoring. So you have every patient is a case by its own.
If I may, I wanted to ask about the use of blood thinners. And I think Hisham just answered it now. Now, what's the panel's opinion about the use of anticoagulation post-op? Do you still use it, or you just depend on your anastomosis? This is number one. In the past, around 20 years ago, I published about the use of recombinant tissue plasminogen, sometimes in cases where you have really a poor circulation, and we had good survival, whether for free tissue transfer flaps, or I started using it for replantation. I would like to hear your opinion as panelists about these two topics.
No consensus on what you give as anticoagulant. So in all the case, we ask the anesthetist to give something. But what is important is to keep the patient 3 or 4 days in his bed, like this, no smoking. He received all the medication, but we start rapidly the physio. So the first day, our physio. First day, even drainage. This is most important, and you should do the bandage yourself, because if you ask the nurse to do the bandages, you will have compression. So this is the first question. The second was about, sorry. No, we don't use this. We do our suture, and when we finish the operation, we know if this finger will continue or not. So this is very, very important. The vein is very, very important. The strategy to operate rapidly is very important. So when the anesthesiologist start the anesthesia, we start working on the finger to search the artery, to search the vein, to do the bilan, if you want. So this is more important. What I have to do, and all fingers are not reprintable, so it is very, very important. Don't have to waste time for a patient with a finger useless. And the trauma is explained. The trauma itself explained, the X-ray explained that this finger will dead. So when you see the complication that you enumerated, so all this complication, we can work on it. So the stiffness, if you have a good fixation, we do rapidly the mobilization. What about the other complications? So we have, so infection is very important, the antibiotics, so we give this. So you should follow this patient, and the procedure, when it's very rapid, so you have less swelling, and less swelling, less compression of your vein, good results.
Honestly, I've seen the difference for post-op anticoagulation in high-risk patients versus non-high-risk patients, either smoking or with multiple comorbidities. So what I saw with different cases, giving the patient for 5 to 7 days post-operative continuous heparin helped in high-risk patients crush injuries more than patients with low morbidities. I've been in several schools. Some schools do not give anything at all post-op. Some schools give anticoagulation. Some schools follow the DVT prophylaxis protocol. Some schools follow the DVT therapeutic protocol. I honestly think it depends on every case and the injury.
Every case is unique.
Yeah.
For my way of giving, after I begin heparin during the operation when I do the first pedicle, the artery, then I continue heparin as long as the patient is inside the hospital for 3 to 4 days with aspirin, and he will continue aspirin for 3 weeks and low molecular weight heparin for 1 week. And it's good. For the other question, I don't have any experience, and it's good to know that you don't have to spend a lot of time doing the fixation. Don't use screws and plates, only rapidly K-wire, the most stable K-wire montage, and go for the doing the vascular sutures. Thank you, Dr.
Thank you.
Abdel Noor.
Knowing that if the fixation fails, you failed all the replant. So we have to be on both sides.
Thank you. Thank you, Dr. Hisham. One question, please. One question. Thank you for a nice presentation and nice work, really, believe me. But some schools doesn't repair the tendon and nerve at this operation, you know, to have a minor tension on this procedure, you know. What do you think about
it? Do not repair tendons and nerves?
Nerve, tendon and nerve.
So they keep the digit non-functional?
Yes, for a later operation.
this is impossible. The aim of this surgery is to go functional as soon as possible. So a finger without tendons or nerves, without having sensory afterwards,
yes, Dr.
sensation
Bat.
and the function. Going into a finger after replantation and dissecting in the fibrosis is difficult for the second time. So keeping the tendons, it takes 2 minutes, the tendon, and the nerve has 2 sutures, 3 sutures maximum. I don't know why they should keep it for a second time.
It's like 30 years ago, because we were not very competent in what we were doing, and we thought, let's first have a vascularized finger, and then we'll come back to do the reconstruction. And this proved that it is really difficult to do. If you have a vascularized digit, you wouldn't dare to come near it again. And definitely it is better to do it from day one and to get it moving as soon as possible. So this is why nowadays, like Dr. Abdel Noor said, stabilize your skeleton, do your tendon, do your artery, do your vein, and then do the nerve at the end.
It's not necessary to do a suture like he explained about the tendon suture. We don't need this good fixation because we don't have time. We don't have time. But for the tendon, the nerve is easy because we have to co-opt the 2 nerves and that's it. But in French school, we said tout doit être fait en un seul temps. Tout. Parce que, like he said, you don't like to return because it's a catastrophic. You have a good digit vascularized, we are happy. And we have 2 things. We have the, when you do a replantation, you have the saxis, the artery saxis. So you have a good finger colored, very good. But don't forget the function. The function is very important. The nerve is more important than the tendon. Because the tendon, we can do arthrodesis. With the stiffness, it will be arthrodesis. But the nerve is very, very painful, and the finger will stay like this, unuseful. So it's very important, the nerve. Thank you. Okay, we will move on to the arthritic thumb, a deep dive into CMC joint arthroplasty with Dr. Rami Al-Abyad.
Hello, everybody. I won't be speaking about arthroplasties. I will be speaking about what we have as solution while we are in front of those arthritic thumb. And I think you are all having young people having pain at the base of the thumb because of the use of the cell phone, smartphone. And we all know that the trapeziometacarpal joint has a saddle shape, as you can see here, it's a saddle shape. It's prone to degeneration because it has a high mobility range, it sustains a lot of loads, and has a potential to instability. Those osteoarthritis of the trapeziometacarpal joint has a range of 30% of people over 50 year old. Usually they are not clinically positive. And when symptomatic osteoarthritis, it will cause pain and limitation of function of the hand and of the pinch and the grip. The etiology of this trapeziometacarpal arthritis remain controversial. Unrecognized joint incongruity and instability will lead to cartilage degeneration. And in young adults, pain in the thumb is usually caused by early osteoarthritis or ligamentous instability. I am insisting on ligamentous instability because if we have to detect those instability early, maybe we can give solution in order not to have progression. And as I said before, we have a lot of basal thumb pain actually because of the use of the smartphone. This is a bad way to use the smartphone. This region is so far, you can't reach it while using is with one thumb. With two thumbs, it's better, but this is the appropriate way and the less harmful way to use your smartphone. And also the space key on the clavier is harmful to the thumb. You know that the thumb moves a lot. It has an abduction, adduction, extension, flexion, mainly opposition, reposition, due to the form of the trapeziometacarpial joint. And while we pinch at the tip of the thumb and index a 1 kilogram force, it will transmit over 12, according to this study, 12 kilogram force at the level of the trapeziometacarpial joint, or according to the study, 3 kilogram force at the level of the base of the thumb. It means that when you even a small pinch, it will transmit and put a lot of compression force at the level of the trapeziometacarpial joint, and it will compress the cartilage. And the aspect of the joint when we pinch, we have a transition of the normal forces at rest. Here we can see on it's green dot, but when you pinch, the forces go dorsally and radially. That's why this joint is likely unstable and it will subluxate dorsally and radially because of the transition of the force from a central part to the lateral and dorsal part of the joint. And unrecognized joint incongruity in early stage will lead to degeneration of the joint, and preventing this maybe will stop the progression of the joint osteoarthritis. We all know the classification of Eaton. It's stage 1. Stage 2, there is a narrowed joint without scaphotrapezial osteoarthritis. It's a little bit subluxated. Stage 3, we have a very narrow joint, normal scaphotrapezial joint, but osteophytes. And stage 3, we have also normal scaphotrapezial joint. Stage 4, we have osteoarthritic changes at the level of scaphotrapezial joint, and we should always consider those osteoarthritis peritrapezial joint to give the best indication. You cannot, on stage 4, you cannot put an prosthesis because the joint of the scaphotrapezial is osteoarthritic and it will give persistent pain. And those are examples you can see here. There is always a component of subluxation, narrowing of the joint, the osteophytes, and the treatment arsenal is divided into joint preserving and joint sacrificing. Joint preserving, medication, injection, splints, denervation, arthroscopic debridement procedure, metacarpal osteotomy. Joint sacrificing, trapeziectomy, trapeziectomy with ligamentoplasty, trapeziectomy with implant interposition, arthrodesis, and arthroplasty. Joint preserving with medication, you can use هيدا عنا إياها منيح الحشيشة, liquid or topical cannabidiol. It gives effect on the pain. You can use supplement as curcuma. It also gives effect, but there is no evidence-based treatment for those supplement treatment for those hand and osteoarthritis. And while using medication, not supplements or topical, and comparing NSAIDs with oral steroids and placebo, there is no conclusive positive result. Intra-articular steroid injection versus placebo, also no conclusive positive result. Intra-articular PRP injection versus placebo, no conclusive result. Intra-articular hyaluronic acid injection with placebo, no conclusive result. The only positive result is with intra-articular PRP injection combined with fat injection. It gives positive result. And PRP, comparing PRP injection VS versus corticosteroids, PRP apparently is better. Thus, these findings illustrate the persistent gap between the mechanism of action and the therapeutic success. Therapy. Should we do physiotherapy? Should we put a splint? In this meta-analysis and systematic review, there is also no clear evidence on splint efficacy, but apparently using a long rigid CMC metacarpophalangeal joint splint is best to relieve the pain, while a short, soft splint is best to recover and increase the function. Also, while this systematic review investigate the effect of conservative intervention in thumb carpometacarpal osteoarthritis, they found out that there is a positive effect of splint on pain and function, but there is no positive effect of physiotherapy on pain and function. While this other randomized control study find out that orthosis plus physiotherapy is better than orthosis alone in pain relief, less conversion to surgery, and better function of the hand. So actually it's better to propose a splint immobilization. It should be a rigid one, and prescribe sessions of physiotherapy. While we go from medication and therapy to surgery, we can propose denervation, but we all know that the nerves that innervate this joint are coming from different sources. The most frequent one and the nerve who innervate this joint are branches of radial nerve, while we have branches from medial nerve and less branches from ulnar nerve. So when we are going to do this denervation, we should address all those nerves, and sometimes we will be missing some branches, so it won't be complete. But it's a solution to consider as a surgical treatment for young people to give them a good pain relief. As you can see here, we have a good pain relief after surgery to improve the strength, but it won't last a long time. Mainly it will last for 1 to 2 years, maybe because of this anatomical variability, and it have been described that we have a revision rate around 25% in those series that have done a lot of denervation. It's a proposition that we should think about in front of a young fellow. Next, it will be the arthroscopy. Arthroscopy, according to this classification of Badia, of arthroscopic classification of the osteoarthritis of the carpometacarpal joint of the thumb, it's a stage 1, 2, 3, 4. I won't go into details. We can do a synovectomy and debridement alone. We can do resection, partial resection of the distal trapezius with ligamentoplasty, or we can do a complete resection of the trapezius with implant, or a partial resection of the trapezius with a pyrocarbon implant. This is what we could do with arthroplasty. Those two types are not preserving techniques. Those are resection technique, but it could be done with arthroscopy. And while comparing all the arthroscopy results doing debridement, arterposition, implants, synovectomy, partial trapezius, they found out that it could improve the visual, the pain, it could improve the DASH score, it could improve the satisfaction of the patient, but those are, they didn't categorize depending on the surgery they have done. They have mixed all those type of surgery just to prove that the arthroscopy is a good way to deal with those osteoarthritis. But also in this study, a meta-analysis comparing arthroscopic debridement with trapeziectomy and joint replacement, they found out that the best result is afforded by the arthroplasty, the less better result was trapeziectomy, and the worst, not worst, the less best, I don't know how to, le moins bon, c'est l'arthroscopic debridement. And when we go through those joint preserving solution, we have to think about also a new trend, fat injection. And those fat injection have been compared with PRP, and apparently it gives good result on pain, improving of disability. The duration of effect is almost 2 years, but it gives significant improvement while comparing them with the corticosteroid. And a combination of the two, I said before in a previous study, gives better result than the corticosteroid. So you can think about it. The last one from preserving the joint is the osteotomy. And the first one who has described this osteotomy is Mr. James Wilson in 1973. And the reason behind this is, as you can see here, there is always a component of dislocation in the radial and dorsal part of the proximal part of the first metacarpal bone, and consequently, there will be an adduction and narrowing of the first commissure, or web space, pas commissure. So it will lead for a Z thumb. This radial subluxation and this adduction give the idea for Wilson to do this osteotomy at the level of the base of the first metacarpal bone, and in order to augment the abduction and widen the first web space to have better function of the hand in pinch and in global prehension. And it shows, this study shows that when this is the normal repartition of the pressure over the joint, it is palmar and ulnar. But when we do the osteotomy, the dorsal osteotomy, it will shift dorsally the forces across the joint, and it will relieve the palmar part, as you can see here, of the joint. And it will unload the palmar part and give more load on the dorsal part, which is at this level and the normal part of the joint. And normally we do a 30-degree, Wilson proposed a 30-degree of closing dorsal osteotomy. Some studies propose 10 to 15 degrees. However, there is no study that correlates osteotomy angle with efficacy. And also some authors propose custom cutting jigs or templates for osteotomy according to a pre-plan done previous to the surgery. And this osteotomy, as you can see here, they have studied using a CT scan at 1 year post-osteotomy. It will relieve the pressure over the joint. This is the preoperative study. This is the postoperative study. The pressure are less at the level of the joint. And this is a study, an old one, that has followed up 8 patients who have been operated for osteotomy and 9-year follow-up in early and moderate osteoarthritis. It is effective. durable, and does not limit future salvage procedure. That was their conclusion. But in this systematic review of 10 publications, they found out that metacarpal extension osteotomy also provides pain relief, improve patient-reported functional outcome, but it does not improve grip strength, does not improve also the pinch strength. So we have less pain, but the strength is not as before and as the normal side. So we will go to joint sacrificing, and we all know those joint sacrificing could be trapeziectomy, trapeziectomy plus ligamentoplasty, trapeziectomy with interposition, arthrodesis, and at the end, the arthroplasty. Trapeziectomy and trapeziectomy plus ligamentoplasty, the first trapeziectomy was done in 1948 by Mr. Jervis. And look how was he assessing the result. The patient was able to start milking within a month of operation and is now, follow up, milking 20 cows a day. This is the DASH score, or that was the DASH score. And he reviewed his trapeziectomy 25 years later, and others also published their result about trapeziectomy alone. And they all come to a conclusion that it gives good pain relief, but weak pinch due to instability, long recovery time, and progressive failure with time because we have subsidency. That's why in the 1971, Eaton and Littler thought about including a ligamentous reconstruction and tendinous interposition after this trapeziectomy in order to stabilize and to give better function. And when we will revise all the publication and meta-analysis, we will end up with a conclusion comparing their trapeziectomy with trapeziectomy plus ligamentous reconstruction. There is no conclusion in terms of functional result. All are equivalent. If we do trapeziectomy or trapeziectomy with ligamentous reconstruction, they are equivalent in long-term comparison study and systematic reviews. The most important for those studies is to remove the trapezius, the cause of the pain and the osteoarthritis. The trapeziectomy and trapeziectomy plus ligamentous reconstruction, also they both do fail because of subsidency and instability. We have observed more subsidency and instability in trapeziectomy alone, but it does exist in trapeziectomy with ligamentous reconstruction. And we have observed because of those revisions, more minor complication in trapeziectomy with ligamentous reconstruction. But always keep in mind that those results of trapeziectomy and trapeziectomy with ligament reconstruction, it will take almost 1 year to recover. It's a slow procedure of recovery. And while we go to trapeziectomy with interposition, using those kind of implants that are made of pyrocarbon, we have special one for the trapezius, as you can see here, trapezius resection, and we have this one for trapezius interposition after resecting arthroscopically or non-arthroscopically the distal part of the trapezius. It gives good result at 5 years, and especially in patient less than 50 degrees. But we are worrying about, as you can see here, the same patient, bone resorption. Look at the trapezius at the beginning and look at the trapezius after 5 years. Maybe it's a temporary solution for young patient. And we will move to arthrodesis. Arthrodesis gave a good functional outcome, low disability, pain improvement, high complication rate because of the risk of malunion, the risk of hardware impingement and neuroma. And it could be done by arthroscopy. And while proposing an arthrodesis, you should always assess the instability, the hyperlaxity. It should be proposed mainly to young manual laborers who had grade 2 or grade 3 CMC osteoarthritis. Contraindication when you have a scaphotrapezial arthritis, poor quality of bone, always send this patient to a hand therapist consultation in order, and you have to insist on how much of motion you will sacrifice or he will lose. Maybe we should do a splint fixing his thumb and try to use his hand with a fixed thumb in order to have an idea before the fixation or arthrodesis. While doing the arthrodesis, you should keep in mind that we should maintain the thumb length, maintain the web space, and avoid excessive shortening. The fixation should be in 35 degrees of abduction, 30 degrees of palmar flexion, and 15 degrees of pronation in mean opposition. And using headless compression screws and dorsal locking plate is the best combination. Staple and tension band wire are not actually used, and it gives pain relief, better stability, superior key pinch, but you always have to think about its consequences in the future, about compensation in the level of metacarpophalangeal joint, at the level of the STT joint, and what it will lead later in the future. And always keep in mind there is a non-union rate. You should always fear this malposition. Closing this web space is a disaster. I've never done it till now, but I have witnessed the consequences. It's a hell when you cannot open the cause of this arthrodesis. That's why this article proposed a hint, an intraoperative hint, putting the hand grip while doing this arthrodesis. You should put the thumb in a hand grip position like this, as you can see here in this photo, in order not to close the web space. And this series find out that the arthrodesis has major effect on DASH score. As you can see here, we have a tremendous improvement of the DASH score and pain, as you can see here, but it has a little effect on grip, pinch, and Kappanji score reaching the fifth finger. And the last but not least, and this is actually a subject that is a hot subject, the arthroplasty. At the beginning, the arthroplasty in the 60s, it was made of silicone, and we all know that it has given a lot of siliconitis. And Jean-Yves de la Caffinière proposed in 1974, a cemented bipolar here and cement on the level of the cup, a metal on polyethylene. The cup was made of polyethylene, and those kind of prostheses gave a lot of loosening, and as you can see here, and revision. While in 2015, using the first implant design from those designs, this article gave a conclusion that total CMC joint replacement does not reliably give better result than trapeziectomy and has some high risk of failure. I think because those designs at this time were not good designs. And you can see here at 2 years, this is the ISIS prosthesis. It is a non-cemented prosthesis of the metacarpal, but a cemented cup in the trapezius. At 2 years, they found out 30% of abnormal radiological images at the trapezial side. 20% of them was radiolucent line, and 10% loosening at 2 years. That's why maybe putting cement inside the small bone is not good. And actually, the good design is a non-cemented cup, uncemented metacarpal implant, metal, you can see here, on polyethylene. It could be a double mobility, as you can see here. It should be a modular neck length and variable offset. And with those new implants, we have 96% of implant survival at 10 years, and this is an X-ray at 8 years follow-up. Thus, now we can compare arthroplasty with trapeziectomy and ligamentous reconstruction. We found out actually with new reviews that arthroplasty is as effective as pain as trapeziectomy and ligamentoplasty, as effective on global functional and disability score. We have higher pinch in arthroplasty, rapid return to work in arthroplasty, better range of motion in arthroplasty, but unluckily, more complication, infection, and more revision in arthroplasty. And arthroplasty also, when comparing it with trapeziectomy, they insist also on fast recovery. So arthroplasty could be a solution for those people who are demanding a fast post-operative recovery. Remember, trapeziectomy, almost 1 year, arthroplasty, almost 3 months. And at the end, always consider surgery after failure of conservative treatment. We have discussed the surgery proposal. Surgical techniques should be chosen depending on age, gender, profession, expectation, local bone condition, and all are good and give good function and good pain release. But arthroplasty has a rapid recovery onset, more pinch strength, more complication. Arthrodesis, better strength, less thumb mobility, overuse of the proximal and distal joint, adjacent joint. Trapeziectomy with ligamentoplasty, slow recovery, less strength, but less complication. You should discuss all those issues with your patient in order to choose the most appropriate solution. Thank you.
Merci beaucoup. Thank you for this presentation. We will start with the question with Professor Mshrafi.
Thank you, Dr. Abiad. This was an explicit and lovely review. I don't have a question, but I have a comment that you've mentioned and which we lack in Lebanon, which is the preoperative assessment of the patient needs, the occupational therapy. This plays a very important role in a lot of hand surgery decisions. And it's vital to know exactly what are the needs of the patient post-operatively and manage them accordingly. The need for a young patient is different from somebody who's old or somebody who's bedridden, etc. So definitely, I hope and I wish that we have occupational therapists that can really assess patients at home and their needs before we embark on doing these surgeries.
Maybe we should insist on, from our side, in order to explain roughly to the patient what he will be after the surgery we will propose.
I know, but
because
you know how difficult it is.
This patient I showed you was operated with arthrodesis. She was suffering, and she told me if I was informed that I will be like this, I wouldn't have accepted this. It's at all levels of surgery, communication is a way to decide the better solution for our patients. Sorry?
How many sessions of PRP you recommend for this case? If you...
I really don't have the experience, but PRP, 1 session.
No consensus.
PRP.
No consensus. Yeah.
And I think that in those articles, it's a review. After reading them, I think that it's one session of PRP, and they have done the evaluation after.
I have one comment. Normally, the CMC joint arthritis is for the rheumatologist is a painless arthritis because at the end it will be painless thanks to the MP joint. So the big problem with this joint is the deformation of the thumb. So when you have a deformation of the thumb, so you don't have a lot of choice. So and when you see these options of treatment, it means no one is good. No one is good. And the rheumatologist, I think they are good because at the end it's painless, and the patient is not demanding. So actually in Europe we don't know all this kind of operation, osteotomy, double osteotomy, a lot of things. I think the young surgeon will not discover this. So we have a good result with the prosthesis, and we have to follow the lower limb surgeon because when you have arthritis in the hip, what you do, you have one choice, and it works. And actually, the prosthesis works. You have to be a good surgeon. You have to the good preoperative diagnosis and the expectation, the age. All this is important. But at the end, if you do nothing, the patient will be okay. But the deformation, we have to explain to the patient that it's a deformative arthritis. This is the difference with the other arthritis.
Yes, as you have said, it's an evolution and it's a learning curve. I think when you go back in the 2000, the reverse shoulder was little time of follow-up was not as actually. And I think the first design of the arthroplasty of the metacarpophalangeal joint of the thumb gave bad result because of the concept. And actually they are giving a very good result at 10 years, as the study showed, because of improvement of the design, uncemented prosthesis, metal on polyethylene, and offset and different length of the prosthesis.
And double mobility.
Double mobility also. So it's a learning curve, it's an evolution, and actually it is giving good result. And rapid result.
Yes.
Rapid result, and you restored the strength. This is important, that you don't have this with the trapeziectomy.
Because trapeziectomy, you lose strength.
Especially when they are very lax. When they are very lax, it's catastrophic when you do trapeziectomy.
I have a comment and I have a question. A comment, we see nowadays a lot of people doing the arthroplasty for the base of thumb. They're not hand surgeons, but they're doing it. Why? Because the approach is simple. We put the prosthesis, we resect, we put the prosthesis. You have to know that the same way you plan your total hip replacement, you have to plan your arthroplasty for the base of thumb. The application of the cup is not standard. As you said, you have an offset, you have the double mobility, and plenty of things might go wrong. So I beg people who are now doing these arthroplasties to know what they're doing. The second thing is that a lot of patients who have base of thumb osteoarthritis, carpometacarpal, they also have a metacarpophalangeal joint pathology. So you start with the Z deformity of the thumb, you're addressing the base of thumb, but we don't address the metacarpophalangeal joint. You have also to address the MCP joint, which is usually hyperextended. And I don't know what's your opinion, Rami, about these things.
I didn't spoke about this, but you are right. It's not only the base of the thumb. You should see the whole column of the thumb. And with putting an overtension while doing prosthesis will decrease the function of the MCP joint and increase the deformity at this level. And as a recommendation from what I have read, when we have a deformity, hyperextension deformity in the MCP joint over 30 degrees, they propose to do a retention of the capsula, volar capsula, plaque palmaire. And over this, over 30. Less than 30, it's not.
The last publication, they talk about until 20 degrees of hyperextension, but reductible, and the correction is done only with the arthroplasty.
30 degrees.
عندي mic. Okay. Rami, I do since many years an excision of the cartilage of the trapezium. Then I do a ligamentoplasty using the extensor carpi radialis, a strip. I pass it subcutaneously under the tendons here. Then I do a tunnel in the base of the metacarpal and a tunnel in the trapezium, and I do a cerclage of the, and it's stable. It's not like the trapezectomy, which is not stable, and they have a good mobility without pain and stable. What do you think about this technique? It's not described. This type of.
It's described. I read about it.
Without interposition. Without interposition, I just excise the surface of the cartilage of the trapezium, and I do a coaptation, a loose coaptation, and with a cerclage.
You put the tendon inside the joint?
No.
Okay.
No anchois.
Okay.
No anchois. Ligamentoplastie de stabilisation de.
I haven't read about it.
It works.
It's not described. I know.
Maybe it's because of
partial.
I have done maybe 20 cases like this, and I have a good follow-up. They are satisfied, and yes.
And then you are stabilizing by this technique. Should publish it.
Sorry, Hisham, but one comment. You know, Bassem Al-Hassan has been doing recently what he does. He resects the trapezium, but then he goes for the dorsal capsule to the palmar aspect. He just put a stitch between them, you know. This will force the thumb into abduction, and it will act as a spacer. And it's working with them, just with the suture, you know.
There is a lot of technique, plenty of technique.
The strengths.
I totally agree.
We should measure it, the grip and the pinch.
Thank you. So it's okay. We will move on because we are very, very late. And now we ask Dr. Youssef Bakkash or Karim. Okay, it's Karim Makawi, who will talk about upper arm nerve entrapment, conservative strategy, surgical anatomy, clinical peers, and pitfalls. Thanks.
So my name is Karim Makawi. I'm a sixth-year plastic and reconstructive surgery resident at AUB, and I'll be presenting today on behalf of Dr. Bakkash on upper extremity nerve entrapments. For the purposes of time, I'll be focusing mainly on the ulnar nerve, going through some general principles and then a new technique that we recently published in the literature. So as an introduction, what are nerve entrapments? So they are focal neuropathies. These result from restriction or mechanical distortion of the nerve within the fibrous or fibroosseous tunnel that it passes through. This usually happens at known anatomic sites of entrapment. So for the ulnar nerve, it could be in the elbow or in the wrist, and usually it is aggravated by specific postures or positions. So it could be due to vibration, forceful movements, repetitive movements, or even work-related activities. And you can see in the chart on the right whereby ulnar nerve neuropathies are the second most common after those of the median nerve. So predisposing conditions, there are a number of conditions that would put patients at a higher risk of having these entrapment syndromes. They are diabetes, thyroid disease, heavy alcohol intake, generalized edema, systemic inflammatory diseases, among others, of course. So these entrapment syndromes, they're not really diseases of the modern age, but they have existed for as long as humans have lived. So going back to the times of the ancient Egyptians, there are a number of hieroglyphs in which they really show manual laborers who are complaining of pain, numbness, tingling in their extremities after pushing heavy loads. A lot of writers who wrote on papyrus scripts who also would complain of pain and numbness of their hands. And going to even more recent times in the 1970s was the Italian physician Ramazzini. So he was known as the father of occupational medicine because he wrote his book to describe the diseases that every occupation would suffer from. And he named it, quite literally, the morbus artificum, which translates to disease of workers. And I'm going to read this quote from his book, which says, "An acquaintance of mine, a notary, used to spend his whole life continually engaged in writing, and he made a good deal of money from it. So first he began to complain of intense fatigue in the whole arm, but no remedy could relieve this. And to offset this, he began to train himself to write with his left hand, but it was not very long because it too was attacked by the same malady." So this was probably a carpal tunnel that he was complaining of at the time. However, it was only until the 1950s when we really had the terms for carpal tunnel and cubital tunnel to really be coined. Carpal tunnel was coined by Dr. George Fallon of the Cleveland Clinic, who we all know from the Fallon sign, whereas cubital tunnel syndrome was coined by Jeffrey Osborne of Liverpool, who is known for the Osborne ligament in the elbow. So to understand these nerve entrapments, we need to understand the path that these nerves follow in the upper extremity, starting from their origin in the brachial plexus. So for the ulnar nerve, it originates from the C8T1 nerve roots. They contribute to the inferior trunk. From there, its anterior divisions would contribute to the medial cord. And the medial cord, as we know, would then contribute to both median and ulnar nerves. The ulnar nerve continues its path along the medial aspect of the arm, passes posterior to the medial epicondyle, and there continues its way through the medial forearm towards the hand. So what is the pathophysiology of entrapment? So what's happening is that we have the compression of this nerve at the known anatomical site. This will compromise the intraneural circulation or the blood supply to that nerve at that given site, and this will then reduce the exoplasmic flow distal to the site of compression. As a result, we'll have hypoxia, we have altered microvascular permeability, subperineural edema, and it is then a vicious cycle where we have more edema, more compression, and eventually fibrosis and permanent impairment of the nerve if it's left untreated. And it is a progressive condition, so with milder form of the disease, you could see that the nerve looks like a normal, healthy nerve, and then going to more severe forms, we start to have more fibrosis, demyelination, and then you see that we have an hourglass appearance of the nerve because of the extensive fibrosis. Some histopathology, so in milder forms of the disease, you can see how we have a good thick layer of myelin around the axon. But with more severe forms, we have more and more myelin loss until eventually we have axonopathy. So the axon itself is also becoming fibrotic and injured. Within the same nerve, you could have areas that are normal, areas in which you have these changes that I have just talked about. And again, you could see how from mild to severe, you really have more and more myelin loss, more and more perineural edema, and more axon loss. So how does this correlate to a patient's symptoms? So with milder forms of the disease, usually the issue here is a blood-nerve barrier breakdown. The patient will complain of intermittent paresthesias, and usually we tend to have positive provocative maneuvers. And here we're talking about, for example, a positive Tinel, a positive scratch conduction test. But for moderate disease, this is where we start to have the subperineural edema, demyelination, and here the symptoms, they become more persistent. And going to more severe forms, this is where we start to have the axon degeneration, the numbness, the muscle atrophy with abnormal two-point discrimination. So these are graphs that show the rates of recovery according to the severity of a patient's entrapment. So for milder forms, this is where we have the dynamic ischemic injury. The patient usually will tend to have an immediate recovery of symptoms. As you can see, right after the compression, we have 100% regain of function, although it may not always be a case of 100%. With demyelination, so here we're dealing with the moderate form of the disease. It is at 3 to 4 months where we have the regain of nerve function. With axonal injury, the axon recovers at a rate of 1 inch per month or 1 millimeter per day. But in most cases, what we have in nerve entrapment is a mixed injury, where we really have a combination of all of these, and we therefore have a stepwise recovery of the nerve injury, as you can see in the final image on the bottom right. Now comes the double crush hypothesis. So this was really published in The Lancet in 1973 by Upton and McComas. And what it basically says is that whenever you have entrapment of a nerve at a specific anatomical site, this patient has a higher risk of entrapment at the downstream site. The reason for that being that once you have this edema downstream and reduced exoplasmic blood flow, you will also have further compression downstream. So for example, someone who has a cubital tunnel syndrome is also has a higher likelihood of having compression at the Guyon canal in the wrist. And this is a chart from a paper in the Journal of Hand Surgery. And again, it shows that a lot of these patients who undergo decompression of a nerve at one anatomical site, they may require within a year decompression of that nerve, either at a different site or of a different nerve. So now, what about treatment? So there are two treatment arms for the cubital tunnel syndrome, the conservative and the surgical. So first, I'll start with the conservative. And in terms of evidence, there is moderate strength evidence that is in support of extension splinting for the treatment of cubital tunnel syndrome. But when it comes to the injection of steroids, they have really limited efficacy on their own, and they have no added benefit when they're given with splinting. And therefore, we could come to the conclusion that conservative management can be recommended for patients who have milder form of the disease or who are able to tolerate extension splinting, which some may not be able to. Now, to understand the surgical interventions, so we need to understand the specific anatomical structures that are compressing the ulnar nerves at each of its compression sites, either in the elbow or in the wrist. So at the elbow, we have four main structures. These are, I've labeled them in red in the images. So A, the arcade of Struthers that links the medial head of the triceps to the medial intermuscular septum. Then there's the intermuscular septum itself, the retrocondylar groove, and the Osborne band or ligament that we've already referred to, which links the two heads of the flexor carpi ulnaris. In the wrist, the structures implicated are the volar antebrachial fascia, Guyon canal, and the leading edge of the hypothenar musculature. And usually when there is a compression at a given site, then we really need to release all of the structures. So for example, in the elbow, we would have to release all four structures. Now, in terms of surgical interventions and treatment for cubital tunnel syndrome, there's really controversy on the literature on what constitutes the ideal treatment. So the two major arms of treatment are to perform a simple decompression, where we simply cut all of the structures that are involved in the compression, whereas the other arm, on the other hand, is to perform an anterior transposition. So we transpose the ulnar nerve anterior to the medial epicondyle. And therefore, here comes the question, to transpose or not to transpose. So there are those who advocate for a simple decompression. They say that it is less traumatic for the nerve, that blood supply is better maintained, But the downside of this really is that the tension is not relieved, because if we are to transpose that nerve anterior to the medial epicondyle, we are really shortening its path along the elbow and therefore relieving tension. And those who, however, advocate for the transposition, the downside of this would be that we do have a partial interruption of the blood supply, and we can also form new compression sites along the path of that nerve. Now, these are forest plots from a paper published in the Journal of Hand Surgery. And again, they compare differences in outcome between both decompression and anterior transposition. And you could see really in both that there is no statistically significant difference in favor of either one of the two procedures. Now, the second forest plot even compares two different modalities of transposition. So the M subgroup, which is that of submuscular transposition, or the S group, that of subcutaneous transposition. And again, there was really no statistically significant difference between the two groups. Again, this is from another paper that aims to compare outcomes, and here they found, again, no difference in efficacy, but they did find that there might have been a slightly higher complication profile with the anterior transposition group. This is another paper from the Journal of Hand Surgery, where they aim to identify the predictors of successful transposition. They looked at 1,500 patients from 26 studies, but they were unable to reach a definitive conclusion because most studies were retrospective, had poor study design, or were highly variable in terms of measurements of outcome, or even the outcomes themselves. Now, from our experience, the surgical prayers for a successful transposition would be, number one, to avoid injuring the medial antebrachial cutaneous nerve, and this would be the main reason for revision surgeries for cubital tunnel decompressions. To perform, again, as I've mentioned before, complete release of the compressive anatomical structures, and three would be to prevent new compression points when the transposition is done. Now, when there is a case of an MABC neuroma, then the treatment could be either resection of the neuroma to cauterize it, proximal crush, or proximal transposition of the neuroma, similar to other neuromas. Again, a compression may also be happening for the ulnar nerve at the Guyon canal, and again, we would need to release the compressive structures that are found at that level in the wrist. Now, in the case of a severe ulnar neuropathy, and here I'm talking about the cases of axonal injury, there are a number of adjuncts that may need to be done. One would be a SETS procedure, which is a supercharged end-to-side anterior interosseous to ulnar motor nerve transfer. The rationale behind this being to preserve the end motor plates that are being supplied by the ulnar nerve and to transfer them to the median nerve-based anterior interosseous nerve. Another would be to perform an FDP tenodesis, where we transfer the FDPs of D4 and 5 that are supplied by the ulnar nerve to D2 and D3. And last but not least, we may need to perform a Guyon canal decompression. Okay, and now I'll end by just showing a recent procedure that we published in PRS Global Open that we call the new cubital tunnel technique. So what we do here is that we start with the usual incision of the cubital tunnel release that traverses the area between the medial epicondyle and the olecranon. And then when we are decompressing the structures, we make sure to preserve a U-shaped or rectangular flap of the fascial structure between the medial epicondyle and the olecranon ligament. So it's found just proximal to the Osborne ligament, and we refer to this as the EOL ligament, or the epitrochleo-olecranon ligament. We do our transposition, and then what we do is that we rotate this flap 180 degrees. So we transpose the nerve anterior to the flap, and then we completely flip the flap 180 degrees and suture it to the flexor pronator muscle fascia. And in doing so, we are able to obtain a new, what we call a neo-cubital canal, where the roof would be this rectangular flap that we created, and its floor would be the muscle. Okay, this is a video. This is an intra-op video where it shows that on flexion of the elbow, there is no subluxation of the nerve. It's held well in place, and at the same time, the flap that we created, or the tunnel, is not too tight to again cause compression for the nerve. Okay, so our results, we acknowledge that we had a small number of patients. We did this on 9 cases. And here you could see the preoperative modified McGowan classification. So 9 of our patients had 2A and above grading scores, whereas postoperatively we had significant improvement of symptoms. 7 patients had no symptoms whatsoever, but 2 patients continued to complain of purely subjective symptoms. Okay, we had a mean follow-up of 6 years. We used another classification to identify our outcomes, which is the Wilson and Crowd classification. 6 of our patients had excellent outcomes, 2 good and 1 fair results. And the mean Prune survey score, which is the patient-rated ulnar nerve evaluation score, was 19.3. So below 20, this is a score that is indicative of minimal symptoms and good function. So in our case, and based on the literature that I've presented in terms of differences in outcomes between surgical procedures, we usually tend to do a simple decompression of the nerve. But when intraoperatively we find that we have subluxation of the nerve across the medial epicondyle or tension on the nerve, that is when we tend to proceed usually with an anterior transposition. Of course, there is no consensus in the literature on optimal surgical technique, whereby current techniques include subcutaneous, intramuscular, and submuscular techniques. Okay, so here it's just to show the pitfalls of each technique. So with the subcutaneous technique, we really have a thin soft tissue coverage. These patients have incisional hypersensitivities, and they tend to have TINL because of that on inadvertent injury to the medial epicondyle. With intramuscular, they tend to have nerve irritability due to traction forces, and with submuscular, it is invasive and requires prolonged immobilization. So our rationale with what we would like to refer to as a subfascial mode of coverage of the ulnar nerve is to really avoid all of the pitfalls that I have just shown on the previous slide and avoiding invasive maneuvers. So to note that in the literature, Goldberg et al., they did use Osborne's band to cover the transposed ulnar nerve in a similar manner to which we did, but we have found that the epitrochleolecranon ligament, it really offers a greater length and therefore less likely to cause compression further down the line for the patient. And we did not observe complications in terms of elbow destabilization or olecranon bursitis. So our paper was able to find for this technique promising preliminary results with a good long-term follow-up. 100% of patients had reduction of symptom severity, but nevertheless, it is important to acknowledge that we had a small sample size, and of course, further studies would be required down the line. Thank you.
Any questions?
Thank you, Karim. This was very nice. I just have a comment about the transposition. I've been doing submuscular transposition since ages, and we've always had good results, and we always use the facial band to suture it to the subcutaneous tissue just to avoid subsequent subluxation of the ulnar nerve. Now, I think nowadays it's a fine line between doing in situ decompression and transposition. And as you grow older, you tend to realize that it is really difficult to distinguish which case, unless you have a very scarred bed, which case that you can do endoscopic decompression and which case you can really need to transpose. I'm not sure whether you have in your mind as panelists any key points that you follow when to do this or that. This is number one. The second thing is that for the past few years, we've been doing a lot of supercharge AIN transfers to the ulnar nerve. Do you have any experience with these? We've done quite a few, and their results are really excellent. And when would you consider nerve transfer, really? At which stage of patients with ulnar neuropathy? Knowing for a fact that if you have irreversible muscle wasting, there's no point of doing anything, really.
So first of all, with regards to the first question, so they're based on the data and based on a recent high-level commentary that was published in the Journal of Hand Surgery. So the conclusion they were really able to reach is that at this point in time, we still do not have sufficient high-quality papers or yeah, they looked at me, so I assumed they did not have sufficient high-quality data or CTs to really come in favor of any of these, to come to a definitive conclusion in terms of favorability of one technique over the other. And there were even some who have decided not to do transposition altogether and just go for in situ decompression. But ultimately, the conclusion they get to is that it depends on the surgeon's experience, how comfortable they are with one technique over the other, and as long as they are able to provide a good result for the patient with minimum complications, then for now, that is the best technique that they would really advocate for.
I personally think that while you grow older, you're doing more transposition. Because while releasing the ulnar nerve from proximal to distal through the Osborne ligament and testing it at the end of this release, you will find that it has a tendency to go anterior, and it is crashed against the epicondyle, epitrochlea. And I've been, while being a fellow with Dominique Leviette, he used to do an osteotomy of the epicondyle, epitrochlea, to decrease the compression of the nerve over the bone. Doing this is a little bit, you have morbidity, so it's easiest to put it and transpose it anteriorly. And I think you have to test the nerve at the end of the release. If it's unstable or if it's crushed, it's better to transpose it.
About endoscopic release, we tried this technique years ago, and we have a good result. But when you reoperate this patient because they are not well, so you have a big nerve. We don't know why we have a big nerve, inflamed nerve. So this is just what we see. So about the supercharge. So we don't do this technique in the compressive of ulnar nerve because the patient arrive before the motor deformation, etc. We don't have this at our clinic. We have it when we have a suture after trauma, suture operated in other hospitals. So we see the patient at 4 months, 3 months. This is a good thing to do. But the supercharge, we think, and from my last Congress in the US, so they discussed a lot about opening the perineurial or just put it on the nerve. So when we open a little bit the perineurial, we do end to a little bit end. It's not end. You see, and this was the discussion there.
Yeah, you know that it is like the two techniques that were described by Susan McKinnon is that either you pull inside the nerve or you push the nerve inside, you know, whether you suture it on the outside or you do a little nick in the epineural. I always do a little traumatic axonotemesis so that, you know, enhance the supercharge onto the nerve.
I prefer the when we do a transfer to the motor branch.
Yes.
And this is good. It gives good result. Of course, before six months.
Yeah.
This is good.
Yeah. Definitely. Now the sensory part, you can do it at a at a delayed stage. It doesn't matter.
Of course, yeah.
Thank you.
Thank you.
So for the last topic, Dr. Sharafi will be presenting what's new in hand surgery in 2025.
Thank you, everybody. Thank you. Okay. I think at this time, I think everybody is tired. It's 2:15, it seems. And I'll go quickly about what has been going on over the past 10 years in hand surgery. For sake of time, I'm not going to spend a lot of time discussing each and every aspect. And in this session, we explore the transformative advances and emerging trends that are really redefining modern hand surgery. Over the past decade, for the past 10 years, innovations in microsurgery, biotechnology, and computer-assisted medicine have really converged to expand both the possibilities and the outcomes in hand surgery. So hand surgery in itself is no longer a standalone specialty. It has a combination of biotechnology, surgical technique, and data science. However, innovation without validation can be dangerous. This is why evidence-based practice remains central to ensure that these new technologies are not only exciting, but also safe. So they should be safe, reproducible, and ultimately beneficial to our patients. Definitely, we'll start with what's going on at the radiology level in imaging. And imaging has advanced significantly over the past decade, and this directly impacts the ability to plan and to execute our surgery. We have high-resolution ultrasonography nowadays for soft tissue and dynamic assessment, and we know that dynamic assessment is very essential when it comes to tendon surgery. Also, on the front of the dynamic MRI for tendon and ligamentous assessment, as well as carpal instability evaluation, this has really advanced. The 3D CT for complex fracture mapping, and we use it a lot, and preoperative surgical planning, it's very essential. All of these imaging innovations refine our preoperative strategy, and definitely you will have a better outcome. Minimally invasive techniques, these have reshaped the way we practice hand surgery a lot. Minimally invasive procedure is not just about smaller incisions, but about faster recovery, better cosmesis, less pain, and more patient-centered care. So starting with the endoscopic and arthroscopic procedures, they're no longer limited to specialized centers. A lot of people now do them. Carpal tunnel release, which was once done in only specialized center, can be done through smaller incisions with a faster recovery. And wrist arthroscopy has become an essential tool, not just for diagnosis, but for treating triangular fibrocartilage complex tears, cartilage lesions, and scapholonate injuries, as well as assistance in open reduction internal fixation of distal radius. The percutaneous fixation techniques for both phalangeal and metacarpal fractures nowadays allow us to stabilize these fractures while preserving the soft tissue integrity, which is very essential in hand surgery to be atraumatic as much as possible. And this results in less stiffness, reduced infection risks, and quicker rehabilitation. Minimally invasive techniques can be also utilized in tendon and peripheral nerve procedures. They have adopted minimally invasive strategies, for example, the limited incision for flexor tendon harvesting or repairs, mini open nerve decompressions, and all of these have demonstrated excellent outcomes while minimizing scarring and adhesions. Overall, as I said, the emphasis remains the same, improving the outcomes and reducing the patient morbidity. The wide-awake local anesthesia, no tourniquet, has become one of the most impactful innovations in hand surgery over the past few years. I know not many of us use it, but it would really help to have a dynamic assessment with the patient wide awake, decrease the amount of anesthesia that you need to have assisting you in the operating room, and it avoids the risks and costs of general anesthesia, decreases resilience and the reliance on the operating room resources, and allows many procedures to be performed in the setting of the clinics. Biologics in hand surgery, you've heard over the past few days a lot of talk about the biologics. Biologics represent one of the most exciting frontiers in hand surgery. The platelet-rich plasma has been explored in tendon repair and peripheral nerve regeneration, with some studies showing improved healing and functional outcomes. However, results remain inconsistent due to difference in preparations, as you heard Dr. Ali Shamsuddin mention yesterday, preparation techniques, dosing, and outcome measures. So not all PRPs are the same. Stem cell therapy, particularly the mesenchymal cells derived from the bone marrow or the adipose tissue with a little bit of partial imbalance towards the adipose tissue, has showed a lot of improvement in cartilage regeneration and nerve repair. The main challenge remains that these are heterogeneous protocols, and we all have small studies to compare. Ultimately, biologics will likely not replace traditional surgery, but they will complement it, providing a multimodal approach to complex tendon, nerve, and cartilage injuries. Vascularized tissue transfer remains one of the most powerful tools in hand surgery, particularly in challenging cases of non-union avascular necrosis and soft tissue loss. Vascularized soft tissue transfers such as free flaps or for coverage and functional muscle transfers play a critical role in restoring both form and function. The benefits are clear. Vascularized grafts consistently outperform non-vascularized options in healing potential and durability. However, they remain technically difficult and demanding, and they will have a definite increase in the operating time and donor site morbidity. Looking forward, the integration of vascularized tissue transfer with biologic augmentation, bone morphogenic proteins, and 3D printing is really holds a very promising future. Advances in super microsurgery for lymphatics is really something that is looked into. It reduces morbidity, refines the techniques, and expands the indications, making vascularized transfers more accessible and adaptable than ever before. The vascularized nerve grafts in hand surgery, you've heard me talk about them before. This is a powerful technique in peripheral nerve reconstruction, and unlike conventional free nerve grafts, vascularized nerve grafts carry their own blood supply, allowing for immediate perfusion once transferred, and this results in an improved axonal regeneration and reduced fibrosis around the nerve, especially important in compromised beds such as scar areas or irradiated areas or previously failed surgery. I'm not going to go much into the details. However, the clinical outcomes have demonstrated faster revascularization, enhanced nerve regeneration, and fewer neuroma formation and complications related to the surgery. Looking forward, the integration of vascularized nerve grafting with adjuvants, such as nerve conduits, bioengineering, like bioengineered scaffolds, growth factors, and stem cells therapy holds promise. And the advances in super microsurgery may also reduce the donor site morbidity and making the vascularized nerve grafts more accessible. Now, innovations in the nerve surgery is going a major transformation as the new tools, the biologics, and the vascularization systems are becoming more and more understood. Intraoperatively, we now have access to high-resolution ultrasound and intraoperative nerve monitoring, which improve localization of nerve pathology and allow functional assessment during surgery. Fluorescein imaging adds another dimension by assessing vascularity and confirming graft viability in real time. Biologics are increasingly being explored as adjuncts in nerve reconstruction. The PRP, stem cells, growth factors show potential acceleration in nerve repair. As I've mentioned, the nerve conduits, nerve reconstruction using these nerve conduits, there are scaffolds guiding regeneration, and if you add on top of them the biologic adjuvants like the PRPs and the stem cells and the growth factors, this will improve the functional recovery in both the tendon and the nerve repair. The bone reconstruction, definitely, as you've all know, that this has advanced considerably over the past decade with the integration of vascularized bone grafting instead of non-vascularized bone grafting. Again, biologics and scaffold technologies has really come into play. Pedicle vascularized grafts from the distal radius are now well studied, and you have a lot of these vascularized pedicle grafts from the volar surface, from the dorsal surface of the distal radius. Definitely these are used for small defects. However, for larger defects, we continue to use free fibular grafts, iliac crests, and the medial femoral condyle. The medial femoral condyle can be used as a cartilaginous graft or an osteocartilaginous graft. These have shown superior union rates to non-pedicled or vascularized grafts. Adjuvants also play a role in bone reconstruction, whether BMPs, PRPs, stem cells, and they all add synergy with scaffolds and 3D printing for osteoarticular defects. Definitely, there is improved union rates in recalcitrant non-unions, and these have expanded the treatment and the reconstructive options, especially in major traumas, tumor surgery, and congenital cases. Tendon reconstruction has advanced significantly in the past decade with innovations spanning surgical techniques, biologics, and rehabilitation. Also, minimally invasive tendon repair became increasingly popular, limited incisions, reduced soft tissue trauma, scarring, and adhesions, while preserving the tendon gliding, and this translates into improved mobility and faster recovery. Again, biologics, PRP, stem cells, growth factors are also being utilized with tendon repair. Experimental scaffolds with bioengineered constructs are also coming into play over the past 10 years. Equally important is the integration of rehabilitation, early active range of motion protocols, once controversial, are now widely accepted when combined with strong repair techniques and biologic protection. You've heard Dr. Abdul Noor talking about the 6-strand technique, and early rehabilitation is very important. Emerging sensor-based platforms provide real-time feedback to both the patient and the occupational or the physiotherapist, ensuring a safer, personalized rehabilitation. Taken together, these advances are leading to faster recovery and reduced complication with better long-term functional outcomes. Advances in small joint arthroplasty with the introduction of pyrocarbon, you've heard Dr. Abiad talk about it, and silicone implants with improved longevity, expanded the indications of the metacarpophalangeal and the interphalangeal joint replacement, joint preserving techniques with osteochondral grafting and biologic resurfacing with interposition arthroplasty and biologic scaffolds is yet another area of advancement. So all of these have been happening over the past 10 years. Emerging therapies against stem cells, PRPs, and growth factors with cartilaginous regenerations, and again here 3D printing and patient-specific implants and scaffolds are other areas of promising advantages with a clinical impact in improved pain relief and motion preservation tailored to the reconstruction of these defects. Coming now to the most advanced part is the artificial intelligence is rapidly really making its way into hand surgery. In diagnostics, the AI-driven algorithms have already outperformed junior radiologists in fracture detection and are increasingly used for recognizing early osteoarthritis, tumors, or even subtle carpal injuries on imagings, and AI is also influencing the surgical planning. Machine learning modules are being developed to predict the likelihood of complications, the union rates, and the non-unions, or even functional recovery after tendon and nerve repair. And this gives us a new level of precision in counseling patients toward what they are going to expect and the treatment strategies. Rehabilitation is another area where AI is being introduced. It's beginning to play a role by using wearable sensors and motion analysis. AI can provide real-time feedback, as I said, to both the therapist and the patient himself, and this will monitor progress and adjust the therapy. However, there are limitations. Algorithms can also be biased, incomplete data sets, and lack sometimes seamless integration into surgical workflows. So you have to take it with a grain of salt. Future directions with the use of AI, AI-assisted intraoperative navigation and robotics is very important. Predictive analytics for personalized surgical outcomes. However, you have to remember the ethical framework for safe adoption. Virtual reality, this is very important for training. Surgical simulation for residents, specialist training is very essential. This gives you an enhanced psychomotor skill in microsurgery and arthroscopy. This will lead to a safe and reproducible, cost-effective environment. Augmented reality, on the other hand, can be used for intraoperative navigation with holographic overlays and real-time visualization of anatomy and implants. So this will improve and assist in complex fracture treatment and reconstruction planning. This definitely will benefit in acceleration of the learning curve for residents, improve precision and confidence during surgery, and expands the global assessment and access to training modules. The challenges remain to have hardware cost and integration into the operating room. The motion sickness that if somebody has really tried to train on virtual reality, this is one of the challenges, and you have to have a user adaptation for it, and limited long-term validation is one of the challenges. Patient-specific holographic surgical guides is the future, and with integration of robotics and AI for hybrid navigation, which will be updated in real time, integrated with robotic assistant for unparalleled surgical precision. Microsurgical advances has benefited tremendously from technological innovations over the last decade. Virtual reality simulators are revolutionizing how we train the next generation of microsurgeons. These platforms allow for repetitive practice of the delicate skills like vessel anastomosis in a risk-free, reproducible, and cost-effective environment. This will shorten the learning curve and reduce dependence on cadavers or animal models. Augmented reality is making its way into the operating room by projecting holographic overlays onto the surgical fields, and augmented reality provides real-time navigation, highlighting critical anatomy and guiding the implant positions. Super microsurgery, we've talked about it with the use of techniques for vessels that are smaller than 0.8 millimeters can now be reliably anastomosed, and this has expanded the indication fields like lymphatic surgery, fingertip salvage, and nerve repair, allowing reconstruction in previously impossible scenarios. Visualization tools have also improved. The modern operating microscopes now provide high-definition optics, while digital 3D exoscopes offer improved ergonomics and team visualization, which is very essential in hand surgery. The combined robotic platforms is also making its way, which will benefit the tremors for surgeons, reducing the motion scaling and enabling a safer and more precise microsurgical procedure. 3D printing and robotics has developed over the past 10 years, and this will help us in the, as I said, in the tremor reduction and motion scaling. The 3D printing is important for patient-specific anatomical models for preoperative planning and custom-made prostheses. The benefits are definitely enhanced precision, personalized surgical solutions, and improved resident education and patient communication. The challenges, as I said, high cost, and the future will be the integration of both AI and augmented reality for hybrid microsurgical platforms. Telemedicine is the last thing that I'm going to talk about. It's very important, especially in remote consultations, triage, and follow-up. Now we're being promised to get a first batch of telemedicine at CMC for medical vital signs assessments. It will get 6 vital signs, a patch that you can apply to the patient, and this will allow for remote monitoring. The same way for remote rehabilitation, with telemedicine, you can have somebody in rural areas and you can video-based therapy, motion tracking devices, and mobile apps. Benefits, definitely reduced travel cost and missed work. Challenges, variable access to technology and internet. You have to have a high-speed internet, and definitely it boils down to who's going to reimburse and pay for these technologies. At the end, the result, it's all comes down to ethics, the data privacy and algorithms and bias with the AI. You have to have regulatory bodies overseeing what's happening, and definitely for the use of biologics. And you've noticed over the past decade how many people are using these orthobiologics right and left. So it has to be really monitored, and you have to balance the innovation with the patient safety, and the surgeon accountability in technologically driven decisions is very important. Definitely, I think the future will be for gene therapy, both for tendon, cartilage, and nerve regeneration, smart bioabsorbable implants with local drug delivery, digital and smart technology, AI-driven navigation, predictive analytics, sensor-based rehabilitation platforms is the future, 3D printing for bone, cartilage, and composite tissue defects, personalized patient-specific implants. However, the guiding principles will remain to have evidence-based medicine and patient-centered innovation for global accessibility. In conclusion, hand surgery is entering a new era of precision and personalization. Integration of these biologics and microsurgery as well as digital technology is reshaping our practice. The surgeons remains responsible for soft adoption and equitable access. Better function, faster recovery, improved quality of life for patients is the future. Thank you very much. Sorry, I went very fast over them because I think you're all tired and you're all fed.